right? The elderly patients are probably the largest consumer of our services, and we don't devote a lot of time in the class to talking about it. So we'll do a quick review and point out some differences and some special considerations that we have to have when we're dealing with elderly patients. It's probably only in the last 10, 20 years where there's actually a field of medicine, and specialists dealing with the management of geriatric patients. So it's kind of like a neglected age group. There's always been pediatricians, but geriatricians is a kind of a newer type of thing. Okay, so I think we all realize that as we get older, right, just like any device, our body has a certain useful life, and as we get older, things start to decline and break down. And there's really two ages. There's your chronological age. So chronological age means, you're either 40, 50, 60, 70, right? Whatever number it is, okay? But then there's your physiological age. In other words, you could have a 40-year-old who has the physiological age of a 20-year-old because he's exercised all his life, he's ate well, kept in shape, and obviously some of it is genetics, right? I mean, he may have genes passed down from his parents and grandparents that he tends to be physically fit and in shape and stuff like that, or she tends to be physically fit and shape. And then, you've also seen the, 30-year-old that's grossly overweight, gets short of breath walking up a flight of stairs. So their physiological age is not that they're, 30 years old. It's more like I'm not like they're 20 years old, more like they're 50 years old. So there's two kind of ages. And that's something when we walk into a house, we even, on a younger patient, we kind of assess, if you see somebody grossly overweight, smoking, I mean, you probably have friends that are this way, or maybe at one point you were that way, right? We all have our periods that we go through where we really don't take care of ourselves and stuff. So those are patients that obviously we worry more about and are going to have more problems and are going to actually have decline in their different organs quicker, right? So that's one thing. Now, as you get older, okay, a couple things change as far as vital signs. Your heart rate tends to go slower, okay? Your respiratory rate tends to go slower, but your blood pressure tends to go higher. So the reason your respiratory rate and heart rate tend to go slower, again, is just the decline in those organs and those muscles and stuff like that. Your blood pressure actually tends to go higher because as we get older, our blood vessels get stiffer, right? When we talked about angina pectoris, right, when somebody's having pain in the chest, it's not a heart attack. We said one of the issues is that the walls of the arteries, okay, besides having fat on the inside of them, have calcium that kind of works its way into those walls. They say infiltrates those walls. And when that happens, the arteries get stiff. And we know that arteries are blood vessels that have to be able to relax and constrict depending on how they need to move blood around. So as we get older, our arteries tend to get stiffer, which means the blood pressure tends to be higher because they don't have the ability to relax as well and stuff like that. Now, this one over here where it says older patients with internal bleeding, it doesn't have to be internal bleeding, but with bleeding, okay, may not exhibit heart rates as rapid as expected. So why would you think as you get older, okay, that somebody's heart rate would not increase as a, compensatory mechanism for going into shock, right? Like normally when we start losing blood volume and our blood pressure starts to fall, our heart rate increases to try to pump more blood to make up for it and keep the blood pressure up. So why do you think in elderly patients you may not see? And there's two reasons you may not see that heart rate increase. Anybody have any ideas?
The muscle becomes weaker.
Okay, so the heart, not only that the heart may become weaker, but what tells the heart to beat, right? We have that internal cardiac conduction system, right? The SA node, the AV node. We have all those specialized nerve bundles in the heart. So you're right. As we get older, right, the heart itself, muscle-wise, gets weaker, especially if you've had uncontrolled high blood pressure for years and years. Because what's the problem? If your blood pressure is high, does your heart have to squeeze harder or easier to pump against that higher blood pressure? So obviously, if your blood pressure is high, that means your heart has to pump harder to push blood out of your left ventricle into your aorta. So it's going to get, weakened. Actually, what happens is it gets very thick, and when it gets very thick, it doesn't really contract with a lot of efficiency, like very completely. Okay, and then also that those nerve pathways, right, start to break down. And then there's one other reason, has nothing to do physiologically with the heart itself, but something that the patient may be doing, taking, or something like that, that would not cause them to get, remember, again, we're saying it's going to fool our assessment because we're going to find somebody who we think may be bleeding, right? And we expect them to start getting
beta blockers.
very good blood pressure medications, right? So there are certain blood pressure medications, okay, specifically ones called beta blockers. Now, that's not what you're going to see on the prescription bottle, right? But that's a class of medications. So beta blockers are medications that typically end in LOL, AL, OOL, you know, something like that. Let me see if I can, whoops, what am I doing wrong here? So here's some, you know, common names of beta blockers. You see how I say they end in OLL, OLOL, right? Sometimes you'll see them. Well, some of these are not common names in America, but AL, right? So that's a common one. Inderol, Propranolol, that's a very common one. Metoprolol, right? Lopressor is the trade name, right? That the company gives it. The generic name is Metoprolol. So just see if we get a little better. Oops. I guess I can't look at that for free. Let's see. So, you know, just again, some common names. So metoprolol, sometimes obviously will have the second name to it, but metoprolol is probably one of the most common ones that you would see. It's showing you how many prescriptions, right? 20 million prescriptions, okay? So a very common one. This Carvedil is also, atenolol is another name, okay? Propranolol. So there's a lot of different names of the medications, but commonly, again, most of them end in LOL, OLOL, AL. Those are mostly beta blocker medications. Toprol is another very common one. So those are all very common medications that people would be on, okay? And the way a beta blocker medication works is that it controls the blood pressure by doing two things, right? So let's back up a little bit. To control blood pressure, right? So you have high blood pressure to the point that you can't get it under control with diet and exercise, okay? One second, I gotta get some latecomers in the class. So you have high blood pressure. You can't get under control with diet and exercise. The doctor says you've tried, it's not working, it's too high, we need to get it lower, and we're gonna put you on medicine. So there's a couple different ways medically or pharmacologically that they would try to get it under control. They could give you a pill called a water pill, okay? So that's usually, you'll see it as Lasix or formaldehyde, or it'll be abbreviated HCTZ, hydrochlorothiazide. Those are water pills. What they do is they increase the amount of water that you urinate out of the body, okay? And they lower your blood pressure by just dropping the amount of volume you have in your body. The danger with that is when you urinate out water, you also take out what's called electrolytes, specifically potassium, okay, sodium, salt. So a lot of times when people are on water pills, they actually have to take electrolyte supplements. They have to take potassium pills and stuff like that because we need all those electrolytes to make the body work. Okay, so that's one thing. And then, you know, it's obviously an issue having to go to the bathroom every hour, right? It's a quality of life issue. They only really give people water pills if they believe the cause of the high blood pressure is fluid overload, that they have too much fluid in their body. Okay, so it's done. It's not the most common way to control blood pressure. Then another class of medications, which what we were talking about, is beta blockers. Okay, so beta blockers decrease blood pressure by two mechanisms. They slow the amount of times a minute the heart beats. So typically people on beta blockers are going to have heart rates in the 60s, right? That's what they usually goal is, to get it down into the 60s. So now the problem is that somebody gets tachycardic, okay, because I don't know, or they're supposed to get tachycardic because their blood pressure, their blood pressure is starting to drop because they're bleeding internally, and the body wants to keep the blood pressure up. So it tries to start speeding the heart rate up, but it can't because the beta blocker is on board and blocking it. The other way that a beta blocker slows down or lowers blood pressure, besides slowing down the heart rate, is that the muscle has to contract, right? So the myocardium, your heart muscle, has to contract. So it actually also decreases the strength at which the heart muscle contracts. So the combination of slowing the amount of times a minute that the heart contracts and also weakening how hard it squeezes controls the blood pressure. So when we go to assess a patient who's on a beta blocker, right, we would not expect them ever to see a tachycardia in them because it's just not common. So if we were looking for tachycardia in our assessment as a sign of symptom and what we thought was wrong with the patient, it would do what's called mask it. In other words, cover it. We wouldn't see it. So just always have to have that in the back of your mind. And then the other thing we talked about beta blockers is that the drug we give to treat for anaphylaxis, which is epinephrine, okay, will not work on a patient who's taking beta blockers very well because epinephrine is a beta drug. So if you have a beta blocker on board, it's going to block the actions of a beta drug. So people having a severe allergic reaction and they're on a daily dose of beta blockers, okay, will not have the same effect of the epinephrine in a life-saving manner than somebody who wasn't. Okay, now, most doctors, before they'd ever put a patient on beta blockers for blood pressure control, will always ask them, do you have a history of allergies? If they say yes, they won't put them on it. But of course, people can have no history of allergies and develop allergies. So it's not 100% that a patient on a beta blocker is never going to have an allergic reaction. Okay, and then the last class of medications, the way they kind of lower blood pressure is by relaxing the blood vessels. Okay, so they always kind of take the pressure off the blood vessels and keep them relaxed, cause a little vasodilation, and that lowers the blood pressure, right? So there's different types, and there's pluses and minuses of all of them, right? So the problem with the water pill, the Lasix, right, makes you urinate. Okay, when you urinate, you lose potassium. Also makes you have to go to the bathroom a lot. So you tend not to get a good night's sleep, right? Trips are hard, long trips are hard and stuff like that. The beta blocker, the issue is that at least for the first couple of months, people feel weak and tired because it doesn't make your heart beat, very strongly. Also, men have problems getting erections when they're on beta blockers. Okay, so again, there's a compliance issue where people say, well, I didn't feel too bad when I had high blood pressure. I didn't even know I had it. Okay, now you're giving this medicine. I'm exhausted. I can't get up. I have no energy. And a lot of people are not what they call compliant with taking it, which means they're not taking it like they're supposed to. Okay, ACE inhibitors, the ones that cause the vasodilation, they tend to give you a very weird cough, it's not a cough like you're sick, but it's like you get a tickle where you cough every so often with it. So it's just uncomfortable that, for no reason you're coughing. And obviously now in the COVID environment, when people are around people who are coughing, they're always afraid they're sick. Okay, so that's the way blood pressure is controlled. And what's the problem with uncontrolled high blood pressure is that, I see some people I didn't put the chat up, hold on. I see, what's the problem with high blood pressure, right? Untreated high blood pressure is one, your organs, okay, of your body, all the different organs of your body were designed, okay, to have blood go through them at a certain pressure, right? And they feel now that the normal blood pressure is like 110/70. It used to be 120/80. Now they're saying 110/70. So if you're running blood pressures higher than that, you're putting blood through your organs higher than it should. So that's going to cause damage. Okay. We said with your heart, if it has to pump harder to exceed a higher blood pressure to be able to move blood, it's going to wear out. Okay. And what typically happens with people with untreated high blood pressure is they wind up getting kidney disease. And a lot of people with untreated high blood pressure become dialysis patients where they have to go on a machine to take the place of the kidneys and stuff like that. It says if everyone would open their video, it would feel more like an in-class lecture. Oh, okay. So in other words, if we could see everybody's faces. Well, don't open your video if you're like, sleeping or eating or whatever. But if you want us to see you, by all means, you can open your video. So that's the danger of untreated leaks. So the only time untreated high blood pressure becomes a 911 emergency that we would go to is somebody has what's called a hypertensive crisis. So hypertension is the medical term for high blood pressure. And a hypertensive crisis means that the blood pressure goes high. And they usually measure high blood pressure by diastolic, not systolic. They usually say a diastolic blood pressure over 130, is a life-threatening emergency. Over 110 is not good, but over 130 is a life-threatening emergency. Now, if the diastolic is 130, the systolic is probably over 200. Okay, but they go more with the diastolic. And people are having hypertensive crisis run the risk of having strokes, right? Having aneurysms in their brain burst and stuff like that. They typically have headaches. They feel nauseous. The light bothers their eyes. So they have very, very clear, signs and symptoms. And obviously the treatment would be to lower their blood pressure, but you can't lower their blood pressure quickly, okay, because then there could be side effects with that, especially if you have no idea how long their blood pressure has been elevated, right? So obviously tonight they called us, so their blood pressure is causing signs and symptoms, but we don't know if it just went up an extra 2 points tonight and all of a sudden now they get that signs and symptoms. They call 911 so I'll give you a number. Let's say their blood pressure was 190 over 120 for weeks and weeks and weeks, and they had no headache, no problems, no nothing. They didn't know it. Okay, now it goes up a couple more points. They get a headache, the light's bothering their eyes, they feel nauseous, they call the ambulance, or they go to the hospital. We don't know how long it's been that way, right? There's no way for the doctor to know that it changed overnight. Okay. Now the issue is if that patient's blood pressure's been high, but not to the point where they had the emergency for weeks and weeks and weeks, the body kind of got used to that high blood pressure. The brain kind of got used to that higher blood pressure. And now if you suddenly lower it, okay, even if you lower it 10 points every couple of hours, the brain can say, okay, I'm not getting enough blood, and change your mental status. So it's just something to, that's why treating high blood pressure emergently is very risky, right? They like to lower blood pressures, okay, unless it's a real life-threatening emergency. Lower blood pressures over days, not over hours. Okay. Okay, so some other problems we have with elderly patients is communication, right? Hearing goes, vision goes, memory goes, and stuff like that. So there's definitely, this I think is supposed to be mentation, not dentation, but mentation means how they're thinking, right? So so it becomes a little harder to speak to them, okay, definitely. Some people may have had previous injuries like strokes, or they may have dementia or Parkinson's, Alzheimer's and stuff like that, where they're not processing the information, so it becomes hard to communicate, find out what's wrong, find out history. We're dependent on family members or caregivers and stuff like that. Okay, now again, remember, if somebody presents with an altered mental status that's sudden, okay, that they're calling you because there's been a change in their mental status suddenly, not over months and months and months, that usually, okay, is some type of emergent problem that we may be able to help with. Maybe their sugar dropped low, maybe they're hypoxic, so there could be something that we could help the patient. If if the mental status has been, declined over weeks and months and stuff like that because of a disease like dementia or Parkinson's or something like that, then obviously we're not going to fix that. Once that happens, it's done. It's not going to get better. So, that's not something we would be able to fix. So that's something you would have to get by speaking to the parents. And we use the term, we always say, like, what's their baseline? So their baseline means, where are they at normally? Do you know what your normal blood pressure is? Does the family know what their normal mental status is? That's their baseline. And then we compare how they are when we're there to their baseline. Okay. Yes, I do see somebody is activating their writing part of the, you can draw on the screen. So somebody's activating, and because I'm screen sharing, it's coming up. That's why that's there. I can't get rid of it. So whoever played with their pen is the only one who can get rid of it. Yeah, so I don't think I can get rid of it.
I think one of the Spiros were writing. A laser, etc.
That's okay. Whatever. It's not a big deal. I mean, let me see if I just shut the screen share off for a second. No. Let me just do this for a second, see if it works. No, it's even on this screen. I'd have to shut my computer off probably and turn it back on. So I don't think there's any way we're going to get rid of it now. Now, when you're speaking with an elderly patient, okay, one, don't assume they're hard of hearing, right? So don't be screaming. And again, just like kids, we said we try to get on eye level with them. They would prefer for you to be at eye level where they could see your lips, because sometimes their hearing has declined, but they compensate by being able to read lips. Okay. Obviously, address them as Mr., Mrs., Rabbi, Rebbitzin, whatever. Be polite. Okay. Introduce yourself. And just show some respect and stuff like that. When we're doing our scene size up, we want to kind of take a look at them. Do they look like they've been bathing, taking care of themselves? Are there any odors that may indicate they're not taking care of themselves? Any injuries, any wounds that don't look like they've been managed? Okay, the condition of the house, clean, dirty, cold, hot. Okay, is there food laying around? Is there fresh food in the refrigerator? In other words, have they been able to eat and stuff like that? So we don't do enough of this, which is, kind of going to patients' homes, elderly patients' homes, and making sure it's safe for them to be there and preventing them from slipping and falling. It's like something that we don't really do a lot of EMS wise. There are some systems that, people can sign up for, like a visit where they go over, safety and everything like that with them. But we don't do a lot of that in New York, and we probably should. Okay. So we know that when we're doing our assessment, right, we're getting a general impression of what we think is wrong with the patient and going through the different steps that we normally do when we learned patient assessment. Okay. History. So history is going to take a little longer in an elderly patient because obviously, one, they have more history. Okay. Medications are much more in detail, right? Many more medications and stuff like that. So, and it may take longer for them to actually explain everything to you. Family members may be present. We like to get the information from the patient to see, how their mental status is. But you could say, just say to the family, well, let them talk to us first, so we can get an idea of, how with it they are. And then, if there's any mistakes or anything they've left out, you could fill us in. Okay, so we always take some time to get history. Okay, we do our physical exam, which is look, listen, and feel, right? We're touching the patient, looking at them, get our baseline set of vital signs. Okay, and then we kind of make a determination of what we think is wrong. And your physical exam, you're basically looking, okay, on a medical patient, you're looking and assessing pretty much every part of the body, right? Remember, in elderly patients, one, because of balance issues, falls are common. Also, two, that the bones themselves start to wear out. Okay, so falls are always an issue and stuff like that. Okay, so it could be involving any part of the body. Unfortunately, elderly patient, say a patient over the age of 70 who gets a hip fracture, statistically, right, lives about only 2 or 3 more years, because hip fractures become very debilitating as far as their quality of life, right? I mean, first of all, they're going to be in the hospital for a while. Second of all, their level of activity is going to decline. Even with the repair, is still going to decline. And then, so prevention is the best, the best treatment, so to speak. Preventing them from slipping and falling and fracturing their hip is better than trying to fix it. They can be prone to infectious diseases, right? So this is classic of somebody who has a viral infection called shingles. There's a vaccine against it. It's actually in a little bit of short supply right now. Shingles is basically a disease caused by the virus that causes chickenpox. So most of the times for somebody to have a shingles problem, they had to have chickenpox. But just because somebody breaks out in shingles and tells you they didn't have chickenpox, the problem could be is they don't remember, their parents didn't tell them they had chickenpox. But what shingles really is that the virus lives dormant in the body from after it was cured as a kid. And then later in life, as your immune system starts to weaken and break down, it comes back. And it causes very, very painful, itchy skin. And in some people, it can move, it can travel back to the brain. It could cause all the other types of problems. For most people, it's just uncomfortable, itchy, and stuff like that. When they're in this stage, these pustules, these sores actually weep. So again, you always have to make sure you have good PPE on and stuff like that when you're dealing with that. Okay. Pelvis again, for trauma. Okay, looking at the ankles for swelling. Okay, so if there's too much fluid in the body or the heart's not pumping effectively, okay, or the kidneys are not working or the liver's not working, you may get ankle swelling, and they call that pedal edema. And sometimes it's both ankles equally, sometimes it's just one ankle more than the other. So it's just something we always look for to get an idea of, their fluid status and stuff like that.
What's the difference between edema and swelling?
Nothing. Edema would be swelling from water, and you could have swelling from other things, right? You could have swelling from muscle inflammation. I mean, the muscle gets like if you were to, I don't know, swing a hammer all day and you don't swing a hammer all day, okay? You know, your nerves, your muscles, everything would kind of get swollen. So you could have that could be just swelling, right? You could have swelling because you burst blood vessels, like a contusion. You know, when we talk about edema, that when they say somebody's edematous, that's typically extra fluid, okay, that's kind of puddling in the skin because it's got no place else to go. Okay. Oh, somebody asked a good question, right? So at what age do we need to, in other words, somebody's 80 years old, how far back in history do we need to go? Okay. So I would say that's a really good question, actually, to be honest with you. It really would depend on what the patient's complaint is. I mean, do you need to go back to when they were 5 years old and find out they had their tonsils taken out? Probably not. Okay. But the reason I'm saying it's a good question is, like, it really depends on the situation. If they're telling you that their mental status kind of changed over a couple of weeks or a couple of, say, a month or two, well, you'd want to find out history-wise, was there a fall? Okay. If they all of a sudden develop diabetes type symptoms where there was no diabetes, you'd probably want to find out if there's a family history of diabetes. So all that kind of knowledge of what to ask and when to ask comes with doing this for a while, right? I mean, you know, the more patients you see, the more patients you talk to, the more patients you take care of, the more times you're on calls with more experienced people and you listen how they do their assessment and stuff like that. That's how you kind of learn those things. History taking, right, is what we're talking about, is really a skill, right? Some people are very good at it and they're very easy to talk to, so the patients open up and talk about a lot of things. And some people are not. And then the other thing you have to realize too is that sometimes patients are reluctant to tell you their different medical problems, especially if, I don't know, it's somebody you know, right? So, I mean, remember, in our community, you may be treating somebody, not only, you may not know them directly, but like all you know is that your brother's wife is their, you know, their niece, and, you know, everybody seems to be intertwined. So it's, you know, it's very hard not to sometimes know someone, and sometimes people are reluctant to share information and stuff like that. I mean, I had a patient that was clearly having a diabetic emergency. They would not admit that there was diabetes in their family because they were marrying off girls. They were marrying off daughters, and they didn't want it to be known that the family had diabetes, a history of diabetes, because they were afraid they were not going to be able to marry off the daughters. So I was like, you know, telling me, no, there's no diabetes. And I said, well, there is now, you know, and then later as we were walking out, they kind of came up and said quietly, you know, there is, but we don't want all the people from Hatzola to hear about it because, you know, that's not what we do in our community. And I was like, okay, you know, whatever. So, you know, you may have, again, some, you know, I always say you have some special obstacles when you're treating, you know, the Jewish population. It is true, you know, and you know that yourself, you know, by dealing with people and stuff like that. And you also know, you know, how easy it is to talk to people and find out that you share common relatives or share common friends and stuff like that. I mean, I'll give you an example. I climbed Mount Washington in New Hampshire with my sons 2 summers ago. So it was like an all-day thing. We get to the top, we're exhausted, or I was exhausted. They weren't too bad. And we missed the train to go back down. So now we were going to have to walk back down. It was already about 4 o'clock. It was summertime, so we've had another, you know, we probably have 4 or 5 more hours. We would have got down, but we really didn't feel like walking down, you know, this thing. And the people that run the top up there said, well, there's nothing to do. You know, train's gone, the vans are shut down. You know, there's no other way of getting down. So I walked out, you know, of the visitor center, and there's, you know, big parking lots. If you've ever been up there, there's parking lots and stuff where everybody who drives up, that's the big thing. You drive your car up there and stuff like that. You know, I look around, and in the distance, I see a bunch of white shirts with yarmulkes. So I said to my sons, hold on for a second. And I walked over. There's a bunch of yeshiva kids on break. And I said, you know, Shalom Aleichem, you have any chance of taking us down? You know, we hiked up, you know, we had our backpacks and everything. Is there any chance of taking us down? So yeah, you know, we got 3 or 4 cars, a bunch of kids, we'll make room. So we load all our stuff in, they take us down. As we're driving, I'm talking to the kid who's driving, you know, the car. And he's telling me that he goes to yeshiva, on Saddle River Road and all this stuff and everything. And I said, oh, where are you from? He says, oh, I'm from Toronto. And I said, oh, I have a brother-in-law, Moshe Bergman. Oh, yeah. My father and him went to yeshiva together. We're friends. Next thing we know is this whole like 20 different people that we knew and everything like that. So that's why sometimes people are reluctant, okay, to, share information, because they feel it's just easy for that information to get disseminated, right? They don't know about HIPAA regulations. They don't know about anything like that. And, that's why people sometimes are reluctant to share information. Now, another issue as people get older, right, and you've seen this sometimes, is they get curvatures in their spine, right? So typically our spine is a little curved, but they get, curvatures in their spine. So let me show you what I'm talking about. Now, this doesn't have to just be an elderly patient, but it tends to be a little more pronounced. Can you see the pictures, or are we still on the slides?
Yeah, we can see the picture.
Okay, so picture this lady fell, okay, and now we're trying to stabilize her spine, her neck, right, and everything like that. So when you put her on the stretcher, her head is still pointing straight upwards. So it becomes just a little more difficult to actually stabilize these people's spines. And a lot of times we have to use a lot of padding, to kind of make up all the voids and stuff like that. They may not be able to lay flat because it could interfere with their breathing and everything like that. So those are just common things that, tend to happen as people get older. So I mean, here it's a little less pronounced, okay, but that can happen. But it can even happen in a younger patient. So just something to think about when you're treating patients where you see that curvature of their spine. Oops. Okay, so all this we pretty much know, right? We have to continue to assess them. Okay, we know vital signs in unstable patients are supposed to take every 5 minutes, which is, I've told you already, doesn't usually happen, because if they're unstable, we're trying to keep them alive. But on a test, you would answer that. Okay, and we usually try to repeat vital signs at least 3 times, while we're with a patient that's stable. In other words, we get our baseline vitals. We'll usually get another set of vitals when we get them out to the ambulance, which tends to usually be a little faster and a little higher than what was in the house, because it's a little scary for a lot of times for patients to be moved out of their home, especially if we're carrying them in the stair chair or the stretcher. Okay. And then we typically get a set of vital signs, as we're arriving at the hospital. So we kind of have like 3 sets of vital signs on patients and stuff like that.
Quick question.
Hmm?
Is it 5 minutes or is it 5 to 15 minutes that you got to keep checking?
So what they're saying here is 5 minutes if the patient's unstable, 15
Good.
minutes if the patient's stable.
Okay.
So I've never seen it as a range. But again, this is typically what they say: 5 minutes in an unstable patient, 15 minutes in a stable patient. What I was saying is, in an unstable patient, you may not have the time to take vital signs, because let me picture somebody gets hit by a car. They're not breathing. Okay. They got blood in their airway. They got broken bones. Okay. So now en route to the hospital, because you're not going to be doing this on the scene because they're a trauma patient, en route to the hospital, you're suctioning, you're bagging, you're splinting, you're giving a report to the hospital, and you're coming from Muncie to Good Sam. So how much time do you really have, right? Because you're scooping the patient up from the scene. You're not doing anything on the scene because they're a trauma patient. You're doing everything en route. So you may not have time to get vital signs every 5 minutes. You may not have time to even get a single set of vital signs. Okay, so, but on a test, you would answer every 5 minutes for unstable and every 15 minutes for stable. But in real life, you'll see sometimes that doesn't happen. Now, elderly patients, because of the amount of medications they're on, sometimes can have issues just because of the medications they're taking. Now, there's a term called medication interactions. So medication interactions mean that the patients are taking a couple different medicines and they interact with each other and cause problems. That is not very common now. Okay. The reason it's not very common is that if the patient's using the same pharmacy or if they have the same insurance, when a patient gets a prescription for medication, it's entered into a computer, right? It's entered into a database. A history of that patient is contained in that. So the computer knows if they put you on if they're putting you on, if you're already on medicine A and that medicine D doesn't work with medicine A, it's going to know that. So if the next doctor writes your prescription for medication D and the computer knows there's a problem with medication A, it's going to flag it. And the pharmacist is not going to be able to fill it until they speak with both doctors and make sure that they want that to actually happen. So now, sometimes that system is bypassed where people start, buying medications through the mail, through Canada, and paying cash for it. Sometimes you'll have people who are veterans who have access to VA, the veterans hospitals, but they may also see private doctors and get medications through a regular pharmacy. So inside the VA system, that would never happen because, again, it's one closed system. And inside the CVS, if that's what they use, CVS system, that wouldn't happen. But now the CVS system doesn't communicate with the veteran system. So that's where you could have issues like that. So it's not as common as it was 20 years ago, before computers became common and stuff like that. So, just before I forget, oh no, actually I did mention, I thought I forgot about the beta blockers in anaphylaxis, but I did mention that. So this is not an uncommon sight to see. Now think about this. You have to find out, are they actually still taking all of these medications? And I'll tell you an interesting thing with elderly patients is once they paid for something, they never throw it away because they often think they may have to take it in the future. So why would I throw it away? Even though by the time they would ever have to take it again, it's probably not good anymore. They just won't throw it away. Okay. So you're going to have pill bottles and you're going to say, are you taking all these medications? No, I'm not. Well, which ones are you taking? The two that are in the right corner are the ones I'm taking, all the rest I'm not. Well, why are they out? They're just out. So, now you have to wonder, are they accidentally taking medications they shouldn't? Are they taking the right doses? And stuff like that. So that is a big issue. We have one truck on the road every day, Monday through Saturday, that it just goes to patients' homes who are hospitalized, but they're not having emergencies now. And we just go and check on them. And what we actually do is arrange their medications. We have cases. It's 30 days with 30 little compartments in them. And it's, they're labeled 1, 2, 3 for the days of the days of the month. And we put all their medications in what they should be taking each day so that the patients can't accidentally take more or less of their medications. And if we go there and check on them and we see they're not taking their medicines, right, then we know that's something we need to look into. So most of the times family does that, right? Hopefully there's family they can monitor and stuff like that. So, but that's, definitely medications can cause issues, right? And when we're going to somebody, one of the questions we want to ask is not only what medications you're taking on a regular basis, okay? We have to also ask them, have you just recently started any new medications or did you recently stop any medications you were taking for a while? Because that can also cause problems, right? The first couple of times you're taking a medication, you could always have a problem till your body gets used to it. Or if you were taking medications on a regular basis and you stop taking them, that could be a problem too. And then if they stop taking them, we have to say, are you stopping to take them under your doctor's direction? They told you to do that, or you're just deciding to stop and take it. Obviously, patients who just suddenly decide to stop and take medications can definitely have problems. Usually if a doctor's telling them not to take it, they start cutting it down the amount they're taking over weeks, so the body gets used to not having it versus just suddenly, stopping to take it. So these are just all things, again, time and experience kind of experience to you. Okay, so the medical term for shortness of breath is dyspnea, D-Y-S-P-N-E, dyspnea, right? Like there's apnea for not breathing, dyspnea for having trouble breathing. So shortness of breath or having difficulty breathing is another way it says it and stuff like that. Okay, is, a common complaint at all ages, right? In younger patients, they could be having an asthma problem and stuff like that. A pulmonary embolism is not uncommon in an older person. Who remembers what a pulmonary embolism is? Anybody remember what a pulmonary? So pulmonary sounds like lung, and embolism is
a clot in the lungs.
But is it in the lungs? Where is it actually in?
Yes, it's in the lungs.
Okay, but what? Tell me where it actually is in. What?
In the bronchi, in the
Nope.
Oh, I'm sorry, in the vein that goes to the heart from the the artery that comes back from the lungs to the heart.
Close. Okay, so now we're getting close. Pulmonary artery. Good. Okay,
From
so,
the heart.
so you're all kind of throwing some good thoughts out there. So the reason I bring this up is that the word pulmonary, right, makes it sound like it's a breathing problem. But a pulmonary embolism is one of the forms of obstructive shock. It's actually a blood flow problem. The patient does complain of shortness of breath, but they complain of shortness of breath not because they're not getting air in and out of their system. They're complaining of it because it's a blood clot that typically originates in your leg, breaks free from your vein in your leg. It's called a deep vein thrombosis, a DVT. It breaks loose from a vein in your leg, okay, and floats up your inferior vena cava, goes into your right atrium, goes into your right ventricle, because those are big, and then goes into your pulmonary artery, okay? And now you know the pulmonary artery comes off the right ventricle and splits because it's got to go to the right and left lung. The pulmonary artery is the only artery that has deoxygenated blood because it's coming from the right side of the heart, which is the blood that the used up blood the body's trying to get back to the lungs. So it comes off, it splits, okay, and then it starts to get smaller and smaller and smaller arteries. Somebody said pulmonary capillaries. So it's true, at the end of the pulmonary arteries would be pulmonary capillaries wrapped around the alveoli, but way before it gets down to the level of the pulmonary capillaries, as it gets into the smaller branches of the pulmonary artery, it gets stuck. Okay, so now it seals off that particular little artery and no blood can get through it. So the reason it's called obstructive shock is when blood is interrupted. So now why do they get short of breath? Well, if they can't get the deoxygenated blood to their lungs to get oxygen, then they're not oxygenating enough blood, so they feel short. But it's not actually any problem with air coming in their mouth, nose, trachea, bronchi, or anything like that. It's not in any of the air passageways. It's actually in the blood vessels bringing the deoxygenated blood from the right side of the heart to the alveoli. Right? So it is it is a big problem. And actually in COVID, there's more and more of it because COVID causes our blood to get a little thicker and it's more likely to have clots and stuff like that. Okay. The other day, somebody texted me about what is COPD, chronic obstructive pulmonary disease. So chronic obstructive pulmonary disease, we talked about in the respiratory section, which is a disease caused nowadays mainly by cigarette smoking. Years ago, it was cigarette smoking and exposure to different types of gases and pollutants when people were doing their jobs. But because now, there's more acknowledgement of it and more regulation, people tend to wear in those types of jobs tend to wear respirators and protect their lungs from it. And there's two kinds of chronic obstructive pulmonary disease. One is called emphysema and one is called chronic bronchitis. And emphysema, the alveoli, which we know are kind of like sacs of air that have rooms inside of them, those internal rooms get destroyed and then it becomes a big floppy sac. And it's hard for the patient to breathe through that sac because it doesn't stay open. Right. So there's a lot of different, types of problems as we get older, but you wouldn't expect a patient to have COPD nowadays unless they had a history of cigarette smoking. Okay. Unless they're coming from a different country, where they would be more exposed to, jobs where they're dealing with dust and smoke and stuff like that and not having the right protection. Okay. One of the things nowadays would be people who work with concrete and they're mixing the concrete as a powder, okay, and that dust, that fine dust can work its way very easily into the lungs. So if they're not working with a respirator mask on, they could be inhaling that into their lungs. And I mean, it's not going to happen in a year. It's going to take, a couple of years of exposure and stuff like that. But it can come. So recap on all the symptoms. I think we're going to start doing that. So somebody's asking, I think you're talking about recap on all the medical emergencies and all the trauma emergencies. So as we start going through the test questions, which we're going to start doing Saturday night, that's what we're going to do. So as I ask you a question and nobody knows the answer to it, I'm going to go through and explain all those different things. Okay. And we'll do a little bit tonight too, because we're going to get done early. So here we got a good example of some different things we could talk about. So angina versus a myocardial infarction. They both cause chest pain. They're both problems with the coronary arteries. So what are the coronary arteries? They're the arteries on the surface of the heart that give the heart itself the oxygen and the nutrients it needs to beat, right? So they're the ones that kind of take care of the heart themselves. Now, what's the difference? Okay. They're both caused that the arteries have fat deposits in them. Okay. But one is a temporary problem, angina, versus one being a permanent problem until we can get to the hospital and have them hospital open up that blocked blood vessel. So an angina typically happens in people in their 60s, 70s, 80s that for years and years and years of not eating properly, they get fat on the inside of their coronary arteries. And before we said tonight, we said that there's calcium and it makes the arteries clogged and stiff, but they're not completely blocked. So most of the times the person with angina, and again, it's a lot of times called angina pectoris because pectoral means your chest in Latin. So it just means pain. Angina means pain. So pain in the chest. Okay. So most of the times they're fine, but when they do something physically difficult, like walking up steps, again, we're talking about elderly patients, walking up a couple flights of steps. I used to go, before I was married, I used to go to Washington Heights for Shabbos. So there's like, 5, 6 story apartment buildings on, I think it was called Bennett Avenue, right where the big shul was. And the people that I used to stay by, on every landing, like in the stairs, every landing, every flat part, there was a chair. And I was like, well, why is there a chair on every single one? Well, because there were so many elderly patients, right? This is a neighborhood that was populated by the German Jews after the Second World War. So there were a lot of people in there back, this is 20 years ago. There were people, they're not alive that I was dealing with, but there were a lot of people in their 80s and 90s that were going to shul and they wouldn't use the elevator on Shabbos, or I don't think those buildings even had elevators, to be honest with you. And they had to walk up these flights of stairs. So they put chairs on every landing so that if somebody was getting tired, they had someplace to sit down on. So that's when you say somebody walking upstairs and they could have symptoms, that was a classic example of it. But anyway, this pain, they get pain in their chest with exertion. It doesn't have to be physical exertion. It could be mental exertion. In other words, they're scared, they get bad news, they get into
Could
an
it be,
argument.
is it a genetic thing?
Nope. It's just a fact of the way we eat, right? Most heart disease is just the way we eat. Yes, you could be more prone to holding on to the fat, right? That's a blood test you have to take. Okay, but really most of it is, us as people, we were not designed to eat as much red meat as we eat. Okay, we were designed to eat more, vegetables and think about it. Most places in the world, meat is a luxury that people may have once or twice a week, right? It's just in America where it's like if you don't have meat 3 times a day, you feel like there's something wrong. So, it's just and the same thing with all the dairy products, right? I mean, it's, again, people used to have milk, I'm sure, and maybe cheese and stuff like that. But, we consume a lot of greasier, fattier foods than our body was ever designed to, handle. So that fat has to get stuck somewhere. And one of the places it gets stuck is in the inside of your arteries. So as we get older, okay, because you don't see these types of problems, okay, in patients who live in Oriental countries, because in Oriental countries, they eat a lot of fish and rice and vegetables, right? So you don't see it as much. So it's a typical problem, more in America. There was a very, if I could find it, I'll send it to you guys. There was a very interesting story of a small town in Pennsylvania between the First World War and the Second World War. So it was probably, the 20s and the 30s. And what happened was that people wanted to leave Italy, okay, after the First World War. There was no jobs, it was tough. So it's a story of basically a town in Pennsylvania, okay, that had stone, like granite, that was used for building. And these small family of stonemasons, people that work with stone, came from Italy and moved to this small town. And life was good in America as compared to Italy. And over about 20 years, they brought over more and more people from their town in Italy. They built a church, they brought over a priest, and they basically developed a community. But it was really the exact community they had in Italy. And it was a community where there was no crime, there were no drugs. The family unit was very intact. So the grandparents were helping take care of the kids. The mothers and fathers were married. There was none of the craziness that we see now. So it was a very stable household. And the interesting thing was that, the doctor, like a local doctor who cared for these people, found that his constituent of patients had no heart disease, where the people who had lived in that area of Pennsylvania all their lives, they did have heart disease. So these newer people that came over didn't have any heart disease, okay? And it was like a community where everybody got together in the evening. Nobody was locking their doors. Everybody knew each other. It was a very, like, I guess, nice place to live. You know, stress level was very low and everything like that. But he published a paper saying how most of his patients just typically in the late 90s just went to sleep one night and didn't wake up. There was no history of people having shortness of breath, having chest pain, even getting sick with colds. There was just none of that. Everybody was very healthy. And when they reached a certain life, you know, one day they just didn't wake up. So there was no suffering, there was no anything, not a lot of dementia, you know, so much different than the surrounding area, people who lived there, you know, all their lives and stuff like that. And anyway, he published this paper and everything like that. So there was a lot of money that was spent trying to study this particular town and why it was so good, because obviously they wanted to copy, you know, what was being done, because it seemed like, you know, a good way to live and everything like that. But what they found very interestingly is that after about 30 years of these people living in America, because now the older people, the founding people, are starting to get older or died off. The kids started having kids. So as generations started to develop, they started to adopt the ways of America. And they started to have all the problems of America. So there started to be drinking. I mean, they did drink wine because that's a very common Italian thing to do, but red wine tends to be good for your blood vessels within moderation. But, you know, there started to be more drinking, more fighting. You know, the family unit was not as intact. There was divorces. You know, that was one of the things also. There was no such thing as divorce, right? People just didn't get divorced. You know, and whatever, it's a very interesting thing. But within 30 years of being here, okay, and starting to interact with the communities around them, they started to develop the same problems as the community around them. Okay, so when you asked me, you know, is it you know how you're born? No, but you can take your good, you know, your good genes, your good genetic makeup and change it by eating poorly. There's also a very interesting article about I don't know, about 5 years ago. It was called Super Size It. Okay, so if you ever go to a restaurant, sometimes you'll see they have like a hamburger, and then they'll say, okay, you can upgrade it and get like an extra patty of meat and French fries and this and that. And that's called supersizing it, right? So this specifically was talking about, I think it was McDonald's, where McDonald's had a special where, you know, you could order a regular dinner, but then you say supersize it, and they give you more French fries and a bigger hamburger and a bigger soda, right? And all this extra crap. So this guy, who I don't know what his background was, he was definitely into physical fitness. You know, I don't know if he was a personal trainer or a, you know, physiologist or kinetic, whatever. I don't know what he was, but he decided that for however long it took, he was going to eat badly. He was going to eat McDonald's like 3 times a day and supersize everything and see how fast his body would get wrecked, so to speak. And it took him about 6 months to get so heavy and so out of shape, and his blood pressure, he had a normal blood pressure, he had everything. It took him about 6 months to start developing medical problems. Obviously, he didn't continue doing it, and he published, you know, a paper on it. Okay, and of course, the McDonald's and the Burger Kings and the Wendy's and the fast food places, they went crazy. And it was about the time where they actually started to modify their menus with more healthy things. And it was also time the government required that the calories of all the different foods be posted because of this. So, you know, you can make your body better by eating healthier, but you could also make your body worse by, you know, eating poorly, making poor choices and stuff like that. And it's something we all battle with, right? You know, we go back and forth, and you might be better in the summer and worse in the winter. You know, everybody's a little bad now because of COVID. So, you know, it's a tough thing. It really is. It's, you know, it's a battle. You know, I mean, some people are very lucky and just genetically they tend to be very thin, but it's a battle that most of us fight, you know, for our whole lives and stuff like that. Okay, so going back to angina. So angina is a problem that takes years and years and years to develop, right? Like I said, it doesn't happen typically until people are in their 70s and 80s. Their arteries get stiff and clogged up. They do get enough blood through them when they're sitting around doing nothing very exciting. But now they're walking up flights of stairs, running for the bus, getting into an argument with someone, having sex, something that's increasing the amount of oxygen their heart needs. But now they can't get it because their arteries are in bad shape. So what happens is they're not getting enough oxygen to their muscle, and they go into that, what we call that anaerobic metabolism, right? Normally we have aerobic metabolism, which is making energy with oxygen. Now they're going to that anaerobic where they're still trying to make energy, but they don't have enough oxygen. They get a buildup of lactic acid in the muscle and it causes pain. Now, most people sit down, right? So they're walking up the stairs. They're going to sit down and say, oh my God, what's happening? And the symptoms start to reverse themselves and get better now because they took away what was bringing it on. So that's the difference from angina and a heart attack. In a heart attack, patients have a myocardial infarction. The problem is that where that fat was, okay, typically the body grows a cap over it to kind of lock it in place. And in a heart attack, for some reason, that cap ruptures and the body thinks there's a wound, okay? And a lot of times heart attacks happen at rest, right? That doesn't have to happen with exertion. But because the body thinks there's a wound, it sends platelets. Platelets are a part of our blood, we said, that kind of causes a clot to develop, and it kind of clots up that artery. And now they're not getting any blood through that artery, and they're having that same chest pain, but nothing's going to open that artery up unless they get to the hospital to have procedures done to open it up. So an angina is kind of like a temporary problem. And angina, if known and diagnosed, the patients are prescribed a medication called nitroglycerin. And we know that nitroglycerin is a medication that relaxes the blood vessels so they can get more blood to where they need to and the pain goes away. Most of the times the pain just goes away because they reverse what brought on the pain. Okay. Now,
Frank, it's interesting what you're saying. My grandfather had angina when he was 35 years old.
Mm-hmm.
So I'm wondering if it's a genetic problem or it's something that maybe he went through the war.
Well, let me ask you. So your grandfather had it. Now, your father, his brothers, your uncles,
My father passed away from a heart attack. Now,
at what age?
60.
Okay. So what you need to do, well, I've never set eyes on you. I don't know what kind of lifestyle you have and stuff like that. But as far as tests go, you should get what's called a nuclear stress test. I just actually had one. So a nuclear stress test is they inject you with a radioactive material into your blood vessel, into your vein, and you sit there, okay, and they let it circulate through your body for about a half hour, and then you run on a treadmill, okay?
Yeah, and that's exactly what my grandfather died from.
Exercising on a treadmill?
He had 35. He was diagnosed with angina. He had
Right.
nitroglycerin.
Mm-hmm.
He had at 50 he had his first heart attack. At 55 he had his second heart attack.
Right.
Then he went to take such a test, a stress test,
Mm-hmm.
and somehow the thing that they put in the dye killed his kidneys, and then that's what.
Okay, so that was probably years ago, right? So first of all, the substance they use now, back then it was it had what they call shellfish, like lobsters, and it had a certain substance from there in there. So I did hear stuff like that. So the stuff they use nowadays does not have that. That's the first thing. It's many years since then. And I can just tell you from firsthand, they're constantly monitoring you. You're hooked up to an EKG. So they're watching what's going on with your heart, and they constantly ask you, are you having any discomfort, any pain, anything like that? Listen, you could be sitting here listening to me talk and be bored to death and die, right? I mean, there's no guarantee how long we're living, right? So, but what that test does, so, I was saying, you're running on this treadmill, your blood contains this radioactive substance, right? And then what they do is after you finish the test, well, actually, let me backtrack. Before you do the treadmill, they inject it with you. They let it circulate through your body. And then you go under a machine that basically takes probably about a half hour's worth of pictures, how that blood with that radioactive dye circulated through your heart. So obviously, if it's circulating through every inch of your heart, you have no blockage anywhere or no significant blockage, okay? If there's areas that's not getting to, okay, then it knows that that could be an area where there's blockage. Then you run on the treadmill, okay? And obviously they're seeing if they can induce any pain in you. They do a calculation. There's a formula based on your age and your weight of how fast your heart rate should get to, okay? And you run in 5-minute intervals with the treadmill changing in speed and incline until you get to that interval, right? Until you get that at heart rate. Then once you get to that heart rate, they disconnect you from get off the treadmill, they disconnect you from all the wires, and you go back under the machine. And now they want to see how the blood is traveling through your heart when your heart is under pressure, under stress, because you just were exerting yourself by running. And then, again, there's a computer involved that kind of analyzes all the data, and they give you your risk, right? In other words, what is your risk of possibly having a heart attack based on how well the blood traveled through all your arteries? So is it 100%? Obviously not, right? I mean, I'm sure there's people who've had that test and been, told everything's wonderful and went and had a heart attack, but that's probably a small amount. And when they do give you all your test results back, they do tell you, that, listen, right now everything looks beautiful. Okay, but that does not mean, that something can't go wrong, because there's nothing that's 100%, when you're talking about the human body. But that's, for somebody who has, so you have a similar family history to what I do. My father died at like 50, of a heart attack. Okay, so, I'm very cognizant of that, because that's something, that, happened in my family. So the only thing you could do, right, is, and again, I don't know what kind of lifestyle you follow and stuff like that, but, staying in shape, exercising and stuff like that, watching your diet, trying to stay away from salty foods, trying to stay away from fatty foods, getting your cholesterol measured, would be a good indication of how much fat you have going in your bloodstream. But really what you need to do is go to a good cardiologist. That's what it really comes to. And we're fortunate, we do have some good cardiologists in Rockland County. If you want to stay in the Jewish world, Dr. Michelle is very good. He's over at Columbia Doctors in Indian Rock, a very learned man, both in medicine and Judaic issues and stuff. So he can have both discussions with you. So there's a couple in that group in the Columbia Doctors. There's actually a bunch of, I use Dr. Roth in there. There's a couple of very good, doctors in there and stuff like that. So you could just go there and say, hey, listen, here's my family history. This is my concern. What do you think? What should I do? And they will develop a plan for testing. And then depending on what your blood pressure is and your cholesterol, hopefully with diet and exercise, you can get to the point where you need to be without having to get on medications. That's always my goal, is to, not be on any medications. So every time they tell me, oh, your cholesterol is a little high today, or your blood pressure is a little high, I say, give me 6 months, and then of course I work out and exercise and watch my diet for 6 months. I get everything repeated. It's perfect. The doctor said, great job. And then I'm sure I get bad again. Such is human nature. But anyway, what can we do for a patient with angina? Okay, so we get there and they're having that pain. Okay, and we can do a couple of things. We can relax them, right? Talk to them. We can put them on oxygen, so we increase the amount of oxygen that their heart's getting. And they probably have a prescription for nitroglycerin. So if you remember, you're allowed to assist the patient with taking their nitroglycerin. Now, by what route does nitroglycerin go? So test question says to you, by what route do you administer nitroglycerin or help a patient take nitroglycerin? Sublingual, and what does that mean?
Under the tongue.
Under the tongue. So before you can give a patient the nitroglycerin or help them take it, you have to check their blood pressure. So what is the minimum blood pressure the patient has to have to be able to 120 over 80? Good. It's systolic of at least 120. Good. And they should not have taken what other kinds of medications in the last 72 hours?
Any erectile
dysfunction medications like Viagra, Cialis, and Levitra. Very good. Okay. And how many total doses of nitroglycerin can you give?
3.
How much do you have to wait in between each one?
5 minutes.
Very good. Okay. Excellent. Okay. So now, what if you give the whole 3 doses of nitroglycerin, they still continue to have chest pain? Now you may not think it's angina. Now you may think they're actually having a heart attack. Okay. How do we know? What should the patient complain of when they take the nitroglycerin to tell us that the nitroglycerin is still what they call potent or active and working? What does a patient usually feel?
Sharpness.
Well, first thing,
under the tongue.
Under the tongue. So they get under the tongue a tingling or burning sensation under the tongue, and they usually get a mild headache, right? That tells us the nitroglycerin is still good. In a myocardial infarction patient, a lot of times they have no history whatsoever, maybe history of high blood pressure, but no, this can happen to somebody at 20 years of age, right? It's just a matter of luck, okay? They have no real history. They're typically not doing anything physical. And most common is to have it early in the morning, just when they're waking up and stuff like that, because this has a different, the cause is kind of the same, which is that the arteries have fat inside of them, but it has a completely different presentation, which is that typically they're not exerting themselves. And no matter what you do for them, okay, the pain continues. But in saying that, we have some things to offer them that will improve their overall prognosis and make it much more likely that they will survive. So what do? We put them on oxygen. Okay, we said that we want to be guided by the amount of oxygen they take by their pulse oximetry. And what's the lowest pulse oximetry we would tolerate?
94.
94%, right? So we don't ever want to see pulse ox. So we titrate our oxygen to always keep them above 94%. Titrate means we adjust it to always keep it above 94%. Now, what else do we have to do for this person? Well, if they do have, okay, good. But if they do have a history of angina and they do have nitroglycerin,
You give them but that's going to take away the pain, right?
no, it may not, because remember, what's going to happen is you're not going to open up that clogged blood vessel, right?
But it
Because
gives
that's
them a
clogged.
little bit of space. No, it doesn't
Nope,
dilate.
no, but what it does, okay, so we're getting off a little bit, but I think this is good because you guys are thinking. Let's find a picture. Okay, so you see the picture of the heart up there? Do you guys see the picture of the heart up there?
Yes, yes.
Okay. So what they're basically saying is that, we know that running over the surface of the heart, okay, are a series of arteries that supply the heart itself with the blood it needs. They originate right off the aorta, and they take the freshest blood, because the aorta has the freshest blood, right off the base of the aorta and send it to the heart, whatever it needs. So the freshest blood first, will be, obviously the heart doesn't need much blood, but the rest goes to the body, but whatever it needs, it takes. So there's a series of big arteries that will have branches of little arteries. If you have a heart attack involving one of the big arteries, you don't have much, there's not a very good prognosis, because you're blocking. In other words, you have a heart attack right here. That means this big blood vessel, this blood vessel are not getting any blood, and all the other ones. So it's not going to be a very, very good outcome, right? But if you were to block maybe one of these tiny little arteries down there, it wouldn't be as bad. So what collateral circulation means is that as the years have gone on, right, and now we're 40, 50 years old, and we weren't eating so good, all these arteries are kind of getting a little clogged up, okay? And that's to be expected, because that's what happens to people. But the body just doesn't say, Frank, you ate too many hamburgers all your life, so you're going to die young. What it says is, okay, I noticed that Frank's not getting enough blood to this section of the heart because these blood vessels are clogged, or this section of the heart because these blood vessels are clogged, doesn't matter where. So what I'm going to do is I'm going to start growing other blood vessels in that same area that's not getting enough blood, okay? And that's called collateral circulation. When you give somebody nitroglycerin, this artery is clogged. It's not going to open up this artery. The only way you open up this artery is with angioplasty to balloon it open, okay? But what it's going to do is it's going to dilate all the other blood vessels in the area they're not involved. So you may actually help the patient, and you may actually change the pain from a 10 out of 10 to an 8 out of 10. So nitroglycerin may not be 100% fix the problem, but it's not going to probably hurt the problem. So, but again,
so it doesn't dilate the arteries?
It does, but again, the artery's clogged.
Now, this one that you're showing, that's the widowmaker, right?
Yeah, well, okay, so
yeah,
that's the term for the left descending coronary artery.
Right.
That covers the left ventricle. So the reason it's called a widowmaker, a widow is a woman who's lost her husband. So the reason it's called a widowmaker is that since it sends blood to the most important part of your heart, if you clog it, the likelihood of surviving it is bad, because clogging your left ventricle is a bad thing to do, or depriving your left ventricle of blood is a bad thing to do. So that's another reason.
But now when you're showing this, now this is a total, it's clogged 100%.
Right.
Mm-hmm. When I give the patient the nitroglycerin, is it not going to give a little bit more room?
I mean, okay, so yes, maybe, but not enough that you're going to solve the problem. It's what's more important is you're dilating other blood vessels in the area.
No, we're just trying to get him to the hospital. Yeah. So it gives me.
That's what I said. It's not going to hurt him. It's just not going to fix the problem. Okay. Now, the problem is that since most patients who have heart attacks have no history, therefore they have no history of angina, they don't have nitroglycerin, and you don't carry nitroglycerin as EMTs. You can assist a patient who has a prescription for nitroglycerin, but you don't actually carry it. The paramedics carry it, but EMTs don't actually carry it. Okay. So now what else do you have to help a patient who's having a heart attack? That's a very important drug, which is aspirin, right? So aspirin does what? So let me actually show you, you know, what's happening in a heart attack, right? So, hold on. I just have to figure out how to share the. Share the audio. Well, let's see if it works. We'll try this one, and if not, we'll do the other one. Let's see. Can everybody see the video?
Yes.
But Grammarly can help. This sentence is grammatically correct, but it's wordy and hard to.
You can all hear this and see this? Can you all
We
hear this?
see it, but we don't hear it.
Okay.
It's very, very low.
It's very low and it's screaming in my ear. So you hear the
Yeah.
music playing at all?
No, we hear it through your
No.
mic.
Oh, through my mic. Okay, so let's see. There is a way of sharing this. Oh, here it is. I found it. Okay. You hear it now, right?
There we
Yeah.
go.
Yep.
Okay.
Atherosclerosis is a life-threatening disease that may have begun to develop during childhood. This condition is a process in which deposits of fatty material, called plaque, build up inside the walls of arteries, reducing or completely blocking blood flow. Although the exact causes of atherosclerosis are not clear, many scientists think it begins with damage to the inner wall of an artery, called the endothelium. Substances traveling in the blood, such as cholesterol, fats, and cellular waste products, accumulate inside the damaged area of the arterial wall. Chemical reactions occurring within the buildup of material cause cholesterol molecules to oxidize. This initiates an inflammatory response in which the endothelial cells at the damaged site release chemicals that signal a call for help. In response, monocytes from the bloodstream travel to the damaged site. Stimulation from oxidized cholesterol converts the monocytes into macrophages. The macrophages eat and digest the cholesterol molecules. As a result of this process, the macrophages change into foam cells, which accumulate to form plaque. As the plaque increases in size, the arterial wall thickens and hardens. At the same time, smooth muscle cells within the arterial wall begin to multiply. Most of the smooth muscle cells move to the surface of the plaque. These cells contribute to the formation of a firm, fibrous cap covering the plaque. Eventually, the passage...
So this is, I mean, this is going into obviously the way deeper than we need to know, but what they just said is that there's a covering that develops over the fat. And that's an important thing, because now what's going to happen to trigger the heart attack is that that covering gets a hole in it. And because there's a hole in it, the body thinks it's a cut, just like a cut on the outside of your skin. And whenever it thinks there's a cut, it sends the platelets to make a scab, right, to cover it. So now it's doing on the inside of the artery, and it seals off the artery, okay? And whatever, we'll talk a little more once we go through it.
Passageway through the artery narrows, enough to reduce blood flow and the amount of oxygen received by the organs it supplies. Over time, the cap may erode and break open, releasing plaque into the bloodstream. The plaque can flow downstream and contribute to the formation of a blood clot, which can stop blood flow. As a result, limited blood supply is available to the area surrounding the partially.
You see the blackened area over here? That's what happens in a heart attack, okay? So that whole area now is not getting oxygenated blood, is dying.
Blocked artery, degrading and potentially killing the neighboring tissue.
This right here.
So it looks like they, you know, because we're not paying for it, we're not seeing the whole thing, but I
They
think
gave a different explanation why it gets clogged.
yeah.
Writing's not that
hold on.
easy, but grammar.
So let's look at this one.
ACS and MI.
Okay, acute coronary syndrome is the catch-all term. ACS, acute coronary syndrome, is kind of the catch-all term for all heart problems. And MI is a myocardial infarction. We usually say an AMI, acute myocardial infarction, means sudden heart attack.
Acute coronary syndrome, or ACS, is a set of one or more conditions that cause the blockage of blood flow to the heart muscles, resulting in a myocardial infarction, or MI. The heart is a muscular organ that pumps blood containing oxygen and nutrients to the rest of the body. The left ventricle is the main pumping chamber of the heart and contracts to send oxygenated blood to the rest of the body through the aorta. Several smaller arteries, known as coronary arteries, are connected to the aorta and supply the muscles of the heart with the necessary oxygen and nutrients. In acute coronary syndrome, there is a blockage in the blood flow through the coronary arteries, usually due to an atherosclerotic plaque, a coronary artery spasm, or a coronary artery dissection. In atherosclerosis, the continued deposition of a fatty plaque results in the narrowing of the involved coronary artery. Rupture of this plaque results in the formation of a blood clot, thereby causing a blockage of the involved coronary artery. The formation of a blood clot is the most common cause of a coronary artery blockage.
So that's showing you right now the most typical heart attack, okay? And when we give the patient aspirin, that's what kind of made me go on this track. So if we give people aspirin, whatever blockage happened before we give them the aspirin is still there. So let me go back a little bit. So what they're saying is that this was the fat that developed inside of the artery, okay? It doesn't have to be the entire artery, it could be in spots of it. The body grows a cap, okay, kind of locking it in place. Now, the cap ruptures, typically because of stress, certain chemicals that are released when you're stressed into the bloodstream. It ruptures, the body thinks there's a wound, the platelets that are floating in the blood start sticking it, okay, and eventually clog it completely off. The person starts to get chest pain because they're not getting enough oxygenated blood past it, and the muscle past it is getting lactic acid built up in it. If they were to call the minute they had chest pain, or if they were to take baby aspirin the minute they had chest pain, they would get no further blockage. The blockage that occurred prior to them calling happens. We can't do anything about that. But the aspirin we'll give them will stop any more platelets from sticking, okay? So what they're doing is they're not correcting their problem 110%. They're just not letting it get any worse, okay? So that's why aspirin is so important. And then when they get to the hospital, they will guide a wire through the blockage, and there's a balloon that then inflates and pushes all of this back open, and then they leave like a scaffolding, like a metal coil clip in here that keeps the artery from collapsing back down. Okay, and that's how they basically deal with it. Okay, so that's the typical heart attack that most people would have. There's other ways, but 90%, 95% of the time, this is the heart attack. I'll let the video run.
Blockage of the involved coronary artery. The formation of a blood clot is the most common cause of a coronary artery blockage. Other less common causes of coronary artery blockage include a coronary artery spasm, which is triggered by drugs, smoking, cold weather or extreme stress, resulting in a sudden tightening of the coronary artery.
A spasm means that it tightens for whatever reasons they were just telling you. So sometimes you'll have a muscle spasm. Your muscle will tighten, you'll get pain. Here they're showing you that the blood vessel is spasming. So obviously it doesn't spasm to the point of complete closure, but it's decreasing the amount of blood that's going through the heart, and that patient will have chest pain. But once the spasm relaxes, it goes away. That's called Prinzmetal angina. It's not that common, but it can happen. So the patient will say to you, all of a sudden, I have this chest pain, and then it goes away. So we say angina, right? That would be our diagnosis. Chest pain that happened and went away. The thing with Prinzmetal angina is it happens at rest most of the time. So now you say, well, wait a second. Can they be having angina without a history of walking upstairs or running or some kind of, exertion? And, so that's when the Prinzmetal angina diagnosis comes in. Again, we don't have to, on an EMT level, we don't have to diagnose to this degree, but you guys seem to be smarter than the average bear, so I'm going into it a little more depth.
Or a coronary artery dissection, in which the inside wall of the coronary artery separates, resulting in a blockage to the blood flow.
So again, an artery has three walls: the inner wall, okay, the middle wall, and the outer wall. So here they're showing you that typically because of, again, coronary artery disease, the same thing that causes the heart problems, the inner wall gets a weakened area in it. And now the blood, instead of going through the lumen where it's supposed to, right, the center, starts to work its way through here, and it's going to cause a bulge to develop, and there could be a rupture, right? That's what an aneurysm is.
Such a blockage to either of the coronary arteries results in oxygen and nutrients failing to reach the part of the heart supplied by it, causing the death of the heart muscle, a condition known as myocardial infarction. Symptoms of a blocked coronary artery include sudden pain or discomfort, tightening, or a burning sensation in the chest, known as angina, which may extend to the upper abdomen, shoulders, arms, neck, or lower jaw. Angina occurring at rest or as multiple episodes, preventing even moderate physical activity, is known as unstable angina and is commonly observed in acute coronary syndrome. Other symptoms of acute coronary syndrome include 1. Breathlessness, 2. Dizziness, 3. Sweating, 4. Nausea. Treatment of acute coronary syndrome, or an MI, usually involves the following. 1. Oxygen therapy, to increase the amount of oxygen delivered to the blood and heart. 2. Aspirin or antiplatelet therapy, to prevent blood clots. 3. Thrombolytic therapy, such as TPA or streptokinase, to break up existing blood clots. 4. Nitroglycerine and morphine, to relax the coronary arteries and relieve the pain. 5. Beta blockers, which reduce the heart rate, thereby decreasing the oxygen requirement. 6. Coronary angioplasty, an interventional procedure in which a balloon-tipped catheter is inflated inside a blocked coronary artery to open it, with a stent remaining behind to keep the coronary artery patent. 7. Coronary artery bypass grafting, or CABG, pronounced as cabbage, a surgical procedure in which the blocked coronary artery is bypassed with a vein or artificial graft material in order to re-establish blood flow to the heart.
Actually, that was pretty good.
Hi, it's Dr. Mark Rosenberg. I used to be the director of the Walter Reed Emergency Department, and I'm recording this.
Frank, can you share that video? I
Um,
think it was a very good one.
yeah. I don't know how to
And
do
what
that.
did you say that there's a medication, two medications actually that dissolve the blood clot?
Yes, so those are called thrombolytics. Before there was angioplasty, we used to give a drug that dissolved the clot. The problem is that side effect of it was people were having strokes. So they only use thrombolytics now if their patient doesn't have access to angioplasty. Remember, most hospitals only have one angioplasty suite. So there could be a patient in there having a heart attack, having angioplasty done. Another patient comes in, and it's going to be an hour, 2 hours before the first patient is done. So they'll give them the option of waiting or taking that medication. So the other time you'll see thrombolytics being done is if somebody has a pulmonary embolism, they can give it and try to dissolve the clot. So yes, it's still a treatment, but it's not the best treatment. The best treatment is angioplasty. So,
But it's not something that ALS is giving. It's a
when it
in the
first,
hospital.
actually, when it first came out, we're talking, some of you might be younger than that, but like say probably 25 years ago, we actually did give it in the field, but then they found after about a year or two that the outcome didn't change whether we gave it in the field or whether it was given 15, 20 minutes later when it got to the hospital. So then they just started waiting till we got to the hospital because it does have a lot of side effects. So, it was definitely better to give it in a hospital than it was in the field because long term, a couple of minutes didn't change the patient's outcome. Okay, so we reviewed angina and myocardial infarction. What I didn't ask you is when would we not give somebody who we suspect having a heart attack aspirin?
GI bleeds.
Okay,
or
more
allergies.
important, allergies.
Allergies.
Right, so if they tell you they have a history to aspirin, you absolutely cannot give it. If they tell you they had a GI bleed 3 years ago, you can give it. If you want to feel more comfortable, you can call medical control. But if they're telling you that they're having chest pain and a GI bleed, then you would have to call medical control and see what they want to do. Usually they would tell you to hold off on it. How much aspirin do we give them?
324 milligram, 481.
481.
325.
25.
Okay, so don't worry about the math. So each one is 81 milligrams. So it's either going to be 324 or 325, depending on how they round it up. Okay, so they usually say 481 milligram baby aspirin. Okay, but if you do 4 times 81, it comes to either 324 or 325 because it's not exactly 81. It's 81 point something. Okay, good. How do we tell them to take it?
Chew it.
Chew it completely and swallow it, right? Not to just swallow it. Good. Just trying to think anything else. We talked about when we wouldn't give it. We talked about when we would give it, how we would give it. Good. Okay. Listen, pretty good. Okay. Pneumonia. What is pneumonia? So pneumo is lung. Okay.
It's a buildup of phlegm in the bronchi.
It's an infection in the lung tissue itself, not the bronchioles, but the actual lung tissue itself. If it was the bronchi or bronchioles, it would be bronchitis. Pneumonia is an actual infection in the lungs themselves, but it is not uncommon for somebody who has pneumonia to also have bronchitis. Okay, so but pneumonia can be bacterial, it can be viral. In other words, the source of the infection can be many different things. It could be fungal. Okay, but it's an infection in the lung itself. And somebody said a lot of junk builds up, which is right? All the infectious materials clog up the lung. Okay, and people who have pneumonia not only can have trouble breathing, but can develop a sepsis where the infection works its way into the bloodstream. Okay, and they can get very sick and die, right? Even just from pneumonia, an elderly patient who has lung problems or breathing problems to start with could die from it. On the field, all we could do is oxygen, okay, and transport. Some pneumonia patients actually would benefit from an albuterol treatment. Okay, so that would be something you could discuss with medical control, but most of the times it would be oxygen. Again, I would use humidified oxygen and transport. An aortic aneurysm, so you know the aorta is the largest artery in your body. It starts at your left ventricle, okay, comes up, arches behind your heart, goes in front of your spine, right down to about the level of your belly button and splits into 2 iliac arteries that bring blood back to your legs, and off the whole length of your aorta from where it basically starts, okay, to where it ends. There's every other major artery comes off of it because the aorta is bringing the blood. So every other artery comes off of that and brings all the blood to the body. An aneurysm, they just showed you in that video, is where the inner wall of the artery gets weakened. The blood peels it back and starts to force the blood, okay, now between the different layers, and a bulge develops, just like when you have a weakened area on your tire, and that bulge could rupture, okay?
AAA.
That's, well, so it depends on where it happens. A AAA is called an abdominal aortic aneurysm. So that means it's a section of your aorta in your belly, but you could also have a thoracic aneurysm, okay, aortic aneurysm in your chest. So it just depends on which section. So the more common place is the abdomen. That's why everybody knows what they call a AAA, abdominal aortic aneurysm. So each word has an A in front of it and stuff like that. Okay, so altered mental status in patients, right, can be many different reasons. Most of the times we don't find out, but I think I've told you a bunch of different times now. When you have the story of a little old person, especially if it's a little old female person who just has no energy, just tired, maybe slow to answer, like not really super out of it, but just not themselves. Most of the times it is sepsis secondary to a urinary tract infection, especially if it's a female patient. Female patients are more prone to urinary tract infections. Okay, so it's a person that has a UTI, urinary tract infection, who's starting to get a little septic. Okay, that's the most common reason in the world. So they're probably going to feel a little warm. There may be some story of problems with urination or burning or pain or, you know, something like that. Okay, it doesn't even have to. It could be or so early that they have no real symptoms and stuff like that. Okay, let's talk about the other things. Hypoglycemia. So hypo means low, glycemia means sugar. So somebody tell me, what is the problem in hypoglycemia?
You got low.
Too much insulin.
Okay, so that's causes. So the problem is, hold on. The problem is there's not enough sugar in the bloodstream. Now, how can that happen? So somebody said there's too much insulin, right? So too much insulin means it would take all the sugar and put it in the cells. So if it takes all the sugar, brings it into the cells and uses it all up, and the person doesn't continue to eat, then you're right. They would have low blood sugar. What is the normal range of blood sugar?
70.
Okay, 60 to 80. Okay, maybe some books have 60 to 100. If you've eaten, it could even be as high as 120. Okay, so that's the normal range in somebody who's not a diabetic. What would be another reason why somebody could have hypoglycemia besides, and again, we're talking about people who have a known history of diabetes, right? So what would be another reason besides they took too much insulin? Could they, what's that?
They didn't eat.
Okay, good. Could it be that they exercise too much?
Yes.
Okay. Could it be that they're having
many what's it called, that seizures?
Seizures?
Yes. If after a seizure, people go low on sugar.
Oh, they could, because you're using, I mean, again, but that's only going to be, again, in a diabetic person, or you could be having hypoglycemia, and because your brain's not getting enough sugar, you could have a seizure. Okay, but let's talk about more common reasons, right? So the most common reason, somebody said already, which is that they took too much insulin. Next most common reason is that they take their insulin and forget to eat. Okay, so now, again, they're not replacing their sugar. It could happen typically in kids that they run around too much and burn up their sugar, or it could be somebody who has a stomach virus and has vomiting and diarrhea, and they're not actually absorbing the sugar in the food they eat. Now, it's very rapid, because once your brain does not get sugar, you become unconscious. Okay, so it's very rapid change in our mental status into unconsciousness. And how does their skin appear? In other words, what's their temperature? What's their color? What's their moisture on their skin?
It's going to be cold.
Very good. So in low blood sugar emergencies, the skin appears like the patient is in shock. It's cool, pale, and sweaty, cool, pale, and clammy, cool, pale, and diaphoretic. Whatever terms you want to use, just like somebody's in shock, but they're not in shock, right? There's no volume, there's nothing, it's a sugar problem. The reason why is that adrenaline is secreted, just like adrenaline is secreted when you're in shock, and that's what happens to the skin when adrenaline is secreted into the bloodstream. Now, what do we do for those patients? So if they're not deeply unconscious and they could safely drink without choking, we can give them anything that contains sugar, orange juice, soda. We can mix, sugar packages into water, whatever we have. Okay, we could give them to drink to raise their blood sugar. If they're unconscious or they cannot safely drink because they have an altered mental status, then all we can do is put them in a recovery position and either transport them to the hospital or try to meet ALS so they can get the sugar intravenously. Okay. Then the high blood sugar emergency, obviously high blood sugar would be hyper, Hyper, hypoglycemia. But that just tells you, that term just says that the sugar in their bloodstream is high. The actual emergency is called DKA, diabetic ketoacidosis. Now, so you told me why the blood sugar would get low. Tell me why the blood sugar would get high.
No insulin.
Okay, so not taking their insulin, good.
Or the sugar is not the sugar is not going to the insulin.
Okay, so they have sugar, they have insulin, but the insulin's maybe not working to transfer it. That's called insulin resistance. Okay, typically happens in heavy people because they're constantly eating too much food and have too much fat. Their insulin, the cells don't really like the insulin anymore, so they don't have to let the insulin carry the sugar in. So the most common reason why somebody's sugar starts to climb is that they get an infection, right? So it's not uncommon for them just to forget to take their insulin, right? I mean, that could happen. But the most common reason is they get a cold, they get an infection, they get a pneumonia. And it just kind of throws their body out of whack, right? It's not working perfectly. And the blood sugar starts to climb. But it takes days, sometimes even a week, for the blood sugar to climb into areas that are dangerous. So this is very slow, where hypoglycemia, the low blood sugar emergency, is very fast, okay? And this one, the high blood sugar, the diabetic ketoacidosis, has other very clear signs and symptoms. So what else does the patient do, mainly to compensate to try to get rid of the sugar, okay, that you would see, or the patient would tell you, or the family would tell you, so you kind of start working your diagnosis? What other history will you hear?
You would run to the bathroom a lot.
Okay, so excessive
eat a lot.
urination. Okay, excessive urination is getting rid of the sugar. So that's called polyuria. You don't have to know that. Just go right. Excessive means too much urination. Okay, so they're not going to the bathroom pooping. They're just going to the bathroom urinating. And because they're urinating out so much and they're losing so much fluid, they become what? Dehydrated and get thirsty. Good. So they drink a lot. And what do they tend to drink? Water, or are they looking for sugary stuff?
Sugary stuff.
Sugary stuff. But why would they be looking for sugary stuff?
Because they're
Wait, this is a high blood sugar emergency. So why would the body crave sugar if there's already too much sugar?
Because they're urinating it out.
It's not going into it's not getting to the place where it needs to get.
It's not going into the cells. So the cells, even though there's plenty of sugar in the bloodstream, it's not going into the cells because there's not enough insulin, right? So what happens is the cells send a signal to the brain saying we're hungry. The brain is still working because the brain is the only organ that doesn't need insulin to bring sugar in. So the brain's getting plenty of sugar, so it's still working, okay? And it basically sends a signal to the person that you need sugar. So now the person drinks sugary substances and eats sugary foods. So they eat a lot, they drink a lot, sugary stuff, and they urinate out. And then the last thing,
a smell of
good. So the other two things is there may be an odor on their breath that smells like nail polish remover, like a fruity odor. Okay, that's all the extra acid in their body. Okay, or all the acid that's building up in their body. I'll explain why in a second. And then they have a very distinctive respiratory pattern. So how do they start breathing? Respiratory pattern means how they breathe. It's called Kussmaul respiration.
Yeah.
And it's deep, rapid breathing, like panting, because they're trying to blow off carbon dioxide. That's a different acid in our body to reduce the acid. So now why do they get acidotic? Okay, because the body starts to try to break down things to make sugar. Even though there's plenty of sugar in the bloodstream, it only knows there's not sugar in the cells. So it's still trying to generate sugar. And the way it generates sugar is it reconverts fat. Fat is a storage form of sugar, right, when we eat too much. Okay, and it reconverts the fat back into sugar. And when it does that, it makes the body acidotic. And that's why the body's urinating to try to get rid of sugar and the acid. That's why it's panting. Now, somebody asked me a couple of weeks ago in class, was it a good question or by text, I don't remember, why does a patient with diabetic ketoacidosis get an altered mental status? If the brain is still getting sugar, why at some point do they get an altered mental status? So the first thing is it doesn't happen quickly, okay, because again, the brain is getting sugar. But the altered mental status is not caused from a sugar problem. It's caused from a dehydration problem from the urination, and it's caused from an acidosis problem. So that's why it takes longer to develop, because the brain is getting sugar. Okay, good. So we went over that. Again, we have no treatment for diabetic ketoacidosis on a BLS level, okay, because we don't carry insulin, we don't carry fluids, right? Those are the two things they need. Okay, stroke we know is typically a blood clot, just like we were talking about in the heart. Okay, it's a blood clot that develops in the brain, in the cerebral arteries that bring blood to the brain, or it's a burst blood vessel in the brain. Remember, a heart attack could also be by a burst blood vessel, just not common, just like a stroke from a burst blood vessel is not common. If it's a blood clot type of stroke, it's called an embolic stroke or a dry stroke. Okay. If it's a burst blood vessel, it's either called a wet stroke because of the bleeding, or it's called a
Aneurysm.
thank you, an aneurysm. Good. Okay. So sepsis is basically a body-wide infection. Okay. Most commonly caused in the elderly by urinary tract infections. Hypothermia means that they're in cold environment, or it could even be it could even be 60 degrees if they're wet, right? They get lost outside, they wander out of the house. Okay, it's a generalized cooling of the body, and pneumonia we said is a respiratory problem in the body.
Okay, and what's the difference between the sepsis and the generalized?
Same thing. Nothing. It's no different. I mean, you know, when you say sepsis, you're saying it's a infection that's gotten into the bloodstream, circulating to the whole body. I don't know why there's both. Okay. Okay. Again, abdominal aortic aneurysm we talked about. Bowel obstructions or blockages mean that there is a blockage in the movement of food through the intestine. Very painful. Again, obviously, if you can't go to the bathroom, you're going to kind of start poisoning your body. So it's people who have excruciating abdominal pain. Diverticulosis, I actually have one of these. Diverticulosis, I'll show you, is, I got that from my mom. Let's see if there's a video on it.
Diverticulitis, the quick facts. What is diverticulitis? Diverticulitis is a complication that occurs when stool and bacteria get trapped in diverticula, which are small pouches or sacs that form in the lining of your intestine, thus causing an infection. If you have multiple diverticula and you are older, overweight, don't exercise, smoke, eat a high-fat and low-fiber diet, or take certain medicines, you have a higher risk of getting diverticulitis. Symptoms of diverticulitis could include pain in the lower left part of your belly, tenderness, and a fever. Doctors usually perform a variety of tests to tell if you have diverticulitis. The tests include a CT scan, a colonoscopy, and blood tests to check for infection and other reasons for belly pain. Mild diverticulitis can be treated at home with rest and a special diet consisting of only liquids and soft foods. Pain medicine is also a common treatment, and sometimes antibiotics are prescribed. More serious symptoms may require a stay in the hospital for treatment such as an IV of fluids and antibiotics, pain medicine, bed rest, and sometimes a needle through the skin to drain an abscess. In some very serious cases, a doctor may need to perform emergency surgery to remove the ruptured part of your intestine.
So it didn't do a great job. Let me show you what it looks like. So
which side of the stomach is going to hit?
It could happen I've never heard it where they say mainly left before, to be honest with you.
And it's a pain that hurts the whole time, or when you press it, or you
no, it hurts.
Let go.
It just hurts.
Just hurts.
You want to know why running on the treadmill 7 days a week?
Hold on. So
it's basically it's when dirt gets stuck inside the wall of the.
Hold on. Okay, so picture this being your intestine, right? Your kishka. So it's a tube. I mean, again, depending whether it's large or small, most of the times it's your large intestine. And again, it's a tube that's smooth, but sometimes people get these little pouches. You see how they have these little things? Now, what's traveling through here is food and, you know, what they call stool, which is the food after it's kind of having everything taken out of it. And sometimes that gets into these little pouches and gets stuck and causes an infection. Okay. So that's what diverticulitis is. The itis means the infection part of it. Diverticulosis means that you have the pouch. Okay, so I mean, it's not uncommon for people to have a pouch. It's just a question of, is it big enough for things to get into it? How many you have? The more you have, obviously, the more chances you're having problems. It is genetic. So if you have parents who had it, there's a good chance that you will have it. And then obviously the risk factors they talked about, right? I mean, again, people who smoke, obviously most people get them after age 50. Okay, and stuff like that. Smoking raises it. Okay, not staying hydrated, making hydration for two different reasons. Okay, that your stool becomes more dry and more likely to break into pieces. It can get stuck and stuff like that. People who take a lot of Motrin, what else? Aleve, like the non-steroidal anti-inflammatories. Drugs tend to have it. People take pain medicines a lot, steroids and stuff like that. People who don't walk a lot, okay, just it makes harder for things to go through and stuff like that. Being overweight, straining a lot when you go to the toilet, right? So this is all comes down to your diet and exercise, right? I mean, why do you strain to go to the toilet? Because you're not eating the right foods, you're not having a lot of fiber, you're not having a lot of moisture, you're not walking around during the day. So it always comes down to the same thing, diet and exercise, even if it just means taking a brisk walk, okay, a couple times a day, will definitely improve your overall, health outcome and stuff like that. Okay. Internal bleeding, we know, happens for a lot of different reasons. It could happen from trauma. It could happen from having weakened areas in your blood vessels called ulcers. So there's a lot of different reasons. You could have cancers that are causing it, ulcers, right? There's a lot of different reasons why people can have problems, with bleeding in there. So typically, you have people who have bleeding are going to start showing the early signs and symptoms of shock. Okay. Dizziness, weakness, malaise. Malaise means you just have no energy and stuff like that. So these are the ones where it really becomes hard in the field to kind of figure out what's going on. These are people that need blood work. These are people who need testing. So all we can really do is put them on oxygen, take them to the hospital and stuff. It'd be very hard to diagnose, what the problem is and that type of stuff. As far as rash and stuff like that, always remember of shingles. The medical term for shingles is herpes zoster. Okay, and it's basically the chickenpox virus that somebody had years, 50 years ago when they were a kid, wakes up again and causes problems and stuff like that. Okay, you have to be careful about coming in contact in the fluid because it is contagious, right? So you have to be very, very careful. I mean, with gloves on, it's not a problem, but you just have to be careful not to come in contact with the fluid and stuff like that. Okay, falls. Obviously can happen. Falls can cause trauma. Falls, I mean, somebody who falls and doesn't even break anything can bruise their ribs and now take a deep breath. And because they can't take a deep breath, they're going to have respiratory components and stuff like that. So falls are very dangerous. People's homes a lot of times are just not safe, right? And elderly people's homes are not safe. I mean, I can't tell you how many times I go to my in-laws. Yeah, I mean, I one time got a call from my mother-in-law that my father-in-law was putting up the sukkah, and he was up on the roof and got scared to come back down. Now, why a man in his, late 70s, early 80s would be going up on a ladder on the roof, I don't know, especially when he has, 2 sons and numerous son-in-laws. But, he was too stubborn to call for help and stuff like that. I walk into my in-laws' house and my mother-in-law's up on a, ladder getting stuff out of the top cabinet of a cabinet in the kitchen. Those are all high-risk procedures. Having loose, tiny little carpets, when you walk in to clean your feet that slide and stuff like that. Not having grab rails in the showers and bathtubs. Those are all high-risk things. So one of the things, you as children of older grandparents and parents and stuff, that's something you need to think about, that at some point, you have to make the home safer. Like I said, I said to my wife, I said, you should really go to your mother's house and everything she has up high that she needs a ladder to go to, you should take down and get rid of. Most of it she doesn't even need anymore, right? This way she doesn't have a reason to go up there and stuff like that. Okay, so really from an EMS standpoint, one of the things we don't do well with is prevention of injury. Okay, and in the elderly, a fall can be a problem. Now, a fall can not just be from something dangerous like going up on a ladder. It could be that they faint because they're having an abnormal heart rhythm, they're having a stroke, they're having bleeding, they're having low blood sugar, whatever the situation is. But we're going to have to first deal with the trauma from the fall, and we may never actually find out the reason they fell. That may be something they discover in the hospital. Okay, so we went through all that stuff. There were some questions.
Asking the patient how they felt before they fell.
Well, the problem is that sometimes they don't know, right? But let me just go back for a second, but hold that thought for a second. Okay, so recap all symptoms that we're going to work on. What do you gain from dilating other blood vessels? So I guess that went back to where we're talking about the collateral circulation and giving the nitroglycerin. So remember, there's a part of the heart that's not getting enough blood, okay, because that particular main blood vessel is blocked. But if you open up the other blood vessels that are in the general area of the problem, you're going to get more blood to that area, right? It's just like, picture you had a picture, look at the roots of a tree, right? The roots of a tree are all down in the dirt. Like, so one root gets blocked, but there's other roots in the general area. So you can't unblock the blocked root, but there's other roots in the area. So if you get those to dilate, then more blood goes to the area, okay? What's these two things above the heart? Mendel, what were you talking about? Two things above the heart where? Mendy? Mendy? You're fixing tires? Mendy? You're there.
I think he meant the flapping.
He think what?
I think he meant the two red, it looked like a tongue flapping on top of the heart when it was moving, when it was pumping. It had like two red.
I got it. It's okay.
In the video? The one where we're looking at the heart, hold on.
Affirmative.
Affirmative.
Okay, it's okay. I got it.
Oh, okay. What was flopping, but now I'm curious.
It was on the video, which when it showed the heart was pumping, it was like two little, one on the right, one on the left kind of
Okay,
thing.
hold
It
on.
was like flapping away. I read something.
Hold on. Heart attack. I think it was this one, right? I think we went to this one. So I don't think it was this one. I think it was the next one. No. Let me go.
You have it
That's
on
the next
picture,
one to the
first
right.
you put on.
This one?
Yeah.
Okay.
Cardiac compromise is a blanket term that refers to many kinds
I thought they talked in.
of
No,
problems
well,
with
there
the
was a
heart.
different one. But you have it on the picture. You see it.
Coronary arteries are deposits on the inner cavity, form blockages elsewhere. That block coronary arteries. Other patients receive an angioplasty, a balloon device to open the artery.
Maybe this is the English version of it.
You can go to YouTube and look your history. It's easy.
Where do you see that?
Just press the first one that you pressed before. And you,
Okay.
okay. Now you see those two on top, right on top of the heart. You have two.
This?
No, low, not before the, right above the heart. You have two pink things on the two sides.
This?
That, yes, and on the other side.
Let me see what they're showing here. Nah. I don't know what this, I mean, I think this is just like a poorly drawn heart. That's supposed to be probably the right atrium. I don't know. I guess because we looked at it, it's not coming up again.
If you go to YouTube, you could go to your history you played.
Oh, I know why we're not on videos. Okay.
Oh,
here it is. This is it.
Christmas came early this year, guys. This pillow is actually scary. It's scary good.
You're pretty scared.
The air grip.
Okay.
Is a set of one or more conditions. MI. The heart is a muscular organ that pumps blood, containing oxygen
Just tell
and
me when you're
nutrients
seeing it.
to the rest of the body. The
You
left
see it now.
ventricle
You
is
see
the
it
main
now.
You see it now?
pumping chamber of the
Atrium.
This thing?
Yeah, that.
Yes.
Oh, okay, so it's just a poor drawing. They're showing you like the hearts in pieces. So that's all it is. They're just showing you like this. They're just
It
showing
doesn't
you.
have the sac around it, I guess.
No, but the heart is not like this. It's not like in pieces. Like if you looked at, I remember there was a, hold on. It was
On this
actually,
video, you see it the same the whole time.
oh, you don't see the actual heart? I thought they showed you an
No,
actual.
no, no.
That was the other video?
Yep.
Okay, so the heart does have distinctive parts to it, but you don't see like cracks in it like this, like it's separated apart. You don't see that. That doesn't actually exist. That's just the way they drew it. So, okay, so what else do we have? The two sides. Okay, so I think we answered that. Okay, so that was all the questions. Does anybody have any other questions? I guess this was, I kind of thought this was going to be a joke lecture, but I guess because we went into so many different things, it actually turned out to be pretty good. So what I'd like to do, you know, whatever we could squeeze in, let's see. So obviously I can do Motzei Shabbos, but I know for some people that doesn't always work. But next week, I can do Monday I'm teaching, Tuesday I'm teaching. So maybe Wednesday and Thursday night, if we want, we could squeeze in a little more review like this. But I really need to start going over questions with you also, because you need to see how they ask the questions, the English part of it, to understand it. So we could probably go through questions, and then if there's things that people don't understand, we could do what we're doing now, which is look at pictures, look at videos to kind of explain it better.
I think Thursday next week is the exam.
It is, but you can't, I don't think you can take it immediately. What David's explaining to me is they have to upload some information or something or other. I'm going to check with them, but he said that more than likely there'll be a delay in taking it, like it won't actually be on Thursday night. And the other thing too is that you don't have to all take it the same night. So, you know, if somebody really feels comfortable and wants to take it, then you can take it as soon as possible. Other people want to do a little more review. I think you have a couple of weeks in, you know, being able to take it. So I have to look into all of that. This is the first time, you know, I've had a class that's doing it the way you guys have to do it, as far as, you know, either going to a testing site or taking it on your own home computer. So I don't know all the little nuances of it, but I'll check with David, because he's been in contact with the state, and see how quick, you know, after we send the paperwork up, will you be able to actually be allowed to take the exam.
I got one question about VTAG and VFib. So VFib is ventricular fibrillation. What's VTAG for? What is that?
It's called ventricular tachycardia. So tachycardia by definition is a heart rate above 100 beats per minute, but this is a more dangerous one, okay, because in this situation, it's the ventricles, the bottom part, the pumping part of the heart. You know, like the atriums are not really do much pumping. They only have to go down to the atrium. So I'm just trying to see if I could find something that would help. Whoops. Okay, so basically, here's how we explain it. In VFib, okay, ventricular fibrillation, the heart is doing no contracting. So there's no blood being pumped. What it's doing is it's just shaking uncontrollably. So there's zero blood being pumped. The patient is dead, okay? The only way to stop ventricular fibrillation is to defibrillate the heart and stop it. So that's where the AED comes in. We do CPR in VFib to try to pump some blood until we get a defibrillator, to try to keep the organs perfused. But CPR in itself will not stop VFib. The only thing that will stop VFib is defibrillation. In ventricular tachycardia, okay, the heart is contracting, but it's contracting too fast, okay? Now, the issue when a heart contracts too fast is that the time between, so let's picture a normal heart rate, 60 to 80. VTAC going at 200, 240. Okay, the time between each contraction is so little that the heart does not refill with enough blood. So even though it's going so fast, if there's no blood making it into it, because the time in between each contraction is so short, then there's no blood to pump out. So the problem that happens when somebody in VTAC is that they're not getting a good cardiac output. They're not getting enough blood coming out of their left ventricle. So all the parts of their body, starting with the heart, because we said that the heart gets that freshest blood right off the aorta, is not getting enough. So VTAC untreated will result in somebody going into VFib and dying. So that's why VTAC is serious, but they're not yet dead. Okay, so the AED, believe it or not, will shock VTAC at a rate of over 150 and will shock VFib all the time. Okay, but they don't want people just putting an AED on someone who's awake, because What happens if they're actually in VTAC? It is over 150, but yet they're lucky and their heart is actually filling with enough blood and pumping. In that case, there might be a safer way of taking care of the VTAC other than shocking their heart. So that's why they always tell lay people, you know, EMTs, everybody, not to put an AED on someone until they're sure they have no pulse. Okay. Somebody had some questions here. It said, why should nitro not help for an MI? I didn't say it wouldn't help. What I said is that it's not going to fix it. What it may help, but it's not going to fix it. Fixing it requires opening up the blocked blood vessel. Okay. So it will dilate the other arteries that are not blocked in the area and get some blood to the area, but it will not fix the problem. They still have to go to the hospital. They still have to have angioplasty. Okay, so it's not that it won't help them. The problem is that most people who have heart attacks have no real medical history. So they definitely probably don't have a history of angina. They tend to be younger. Okay, so, you know, it hasn't developed to the point where they're getting chest pain with exertion or anything like that. So they don't have nitroglycerin. So it's kind of a moot point because we're not going to even have the nitro to be able to assist them in taking. And then somebody else just asked, is VTAC SVT? No. So there's two different types of tachycardia. One deals with the ventricles, one deals with the atriums. So VTAC deals with the atriums. SVT stands for supraventricular. Supra means above the ventricles. So supraventricular means above the ventricles. So SVT tends to be a little more stable than ventricular tachycardia because, again, the ventricles are the more important chambers of the heart.
I got one more question.
Absolutely.
Would you, so, you know, sometimes when you go running, you feel your bottom, you know, below your ribs that starts hurting. Would you call that angina, or that's just poor muscle?
No, that is, so you're talking, you get pain that then when you stop.
Acid.
Yeah, it's basically exactly, it's lactic acid building up in your muscles that you're using with running. So it's typically lactic acid in your diaphragm and your intercostals. Okay, and that's why you're feeling the pain over by your ribs and stuff like that. That is just that you have exercised harder than your body's used to, and it can't get enough oxygenated blood to the area. So that's not angina, because pretty much that goes away the minute you stop running, right? It goes away almost instantaneously. Where angina typically takes a while, you know, like it take up to 5-10 minutes to go away. So that happens, you know, that even happens, like you could have people who just start walking, right? And you know, to exercise. So it's the first couple of days they're walking, and then they'll say to you, well, I'm getting pain in my side. That again just means they're walking a little faster than their body's used to, and they just have to wait, you know, they slow down a little bit and they wait another week or two to start walking at that speed, because they will slowly start conditioning in their body, you know, and they won't get that pain, or at least as quickly. So that's just a matter of, you know, getting in better shape, I guess would be the thing to say, conditioning, you know, your body to that level of exertion.
Understood.
Frank, I asked it once. I just want to re-ask. Angina could kill someone, or it's just
usually not, because angina, when you sit down, goes away, right? So how is angina going to hurt? So it happened this winter. So the only snowstorm we had, that big snowstorm, there was a guy shoveling the snow. He was the fire inspector in one of the towns. He was shoveling snow, having chest pain. And when he'd stop shoveling the snow and rest for a little bit, it would go away. But he really wanted to get the snow done. It's a man thing. It's a stupid thing. And he continued to shovel the snow, and he actually exerted his heart so bad to the point that he actually now moved into the heart attack. But that's very rare, because most people who have chest pain say, oh my God, what's happening? You know, they sit down and they call the ambulance, right? Or they call their doctor. So this guy just literally worked himself up into a heart attack, you know. And
is he a good inspector?
I don't know. It was not my town. So, but you know, so is it possible? Yes. Does it happen? Very rarely, you know, so it's not common. But in one of the videos we watched, they actually threw out a term called unstable angina. So that actually is considered a risk factor of a heart attack. So the difference between regular angina and unstable angina is very simple. First of all, you had to have regular angina to get unstable angina most of the times. But what it means is that you had to usually walk up, let's say, you had to walk 2 miles before you got chest pain, or you had to walk up 4 flights of stairs before you got chest pain. That was your typical angina threshold before you got pain, right? A certain level of exertion before you got pain. Now, all of a sudden, you notice that when you walk up 1 flight of stairs, you start getting chest pain. You walk 2 blocks and you start getting chest pain, okay? That's considered unstable angina, which means that the symptoms are coming on with a lot less exertion, a lot less activity. And that's considered a precursor or a warning sign that a heart attack is imminent. So that's called unstable angina, or angina. Unstable angina is used interchangeably. So if somebody says to you, and again, this is not going to be usually a patient that calls to your house. This is going to be some guy sitting next to you in shul who knows you're an EMT. And he says, it's probably nothing, but let me ask you a question. This is how it always starts. Or it's going to be at a chasana or something like that, bar mitzvah. It's probably nothing, but let me just ask you a question. And he said, usually, I had this thing where, I went for a walk on Shabbos and I usually was able to go a mile and never had any problems. Now I go a little bit and I get short of breath and maybe I get a little pain. What do you think? So that's considered unstable angina, right? Where they're telling you, usually they used to be able to do a lot more and now they can't before they get pain. Okay. So, that would be unstable. That would be somebody considered to be at greater risk for having a heart attack, But I mean, I told you guys, the reason I went for all this testing was I was climbing the side of this, mountain up in the Catskills, and I was pretty much almost to the top, so it was hard, and I got chest pain, and I'm like, oh my God, I have chest pain, So I was like, well, I can't stop now, typical stupid man. And I continued going. So I got to the top and sat down, had a drink of water, and the pain went away. So I was like, okay, whatever, no big deal. But then I happened to notice that when I started to do some, heavy physical activity, like I was mowing the lawn on a Sunday, for like an hour and a half, about towards the end of the hour, I started to feel a little pressure in my chest. So I'm like, oh, something ain't good, So that's why I started going for all the cardiac checkups and stuff. Well, I was able to figure out what it is I actually have, there's a muscle when your esophagus comes into your stomach, there's a muscle at the bottom that keeps the acid in your stomach from coming up. And when I would exercise after eating, okay, I would get some acid coming back up. Okay, so how did I figure this out? So after I spent, all this time and effort with all these tests and everything came back normal, I said, let me try to exercise without eating and see if that does it. And then all of a sudden, I never got any problems if I would go on an empty stomach, other than I would get shaky because I didn't have any food, but I get no chest pain. Then I said, okay, let me eat and take some antacids, medicine that prevents you from having reflux, and see if that works. And it did. So I was like, okay. So then when I went back to the cardiologist and said, okay, so all your tests are negative, but let me tell you what I did. So he's like, oh, that's pretty good. He goes, okay, so now you have to go to a gastroenterologist and have what's called an endoscopy, which is they put you to sleep and they put a tube down your throat into your esophagus, and they go look at your esophagus and they look at then, what they call the esophageal sphincter, that muscle. Then they go through it and then they look around in your stomach. So when you do a colonoscopy, they start at the bottom up your butt and they look through your intestine. And this one, they're going from the top and they look at your esophagus and your stomach. So that's the next step. And I don't even know what I'm going to do with, because when I talked to gastroenterologist, I said, so you find out that I have a weak esophageal sphincter, what are you going to tell me to do? And he said, oh, be some modification of what you eat, no spicy foods, no onions. I eat a lot of onions, no onions, no spicy food, try to eat smaller meals, try not to eat before you exercise, so everything I'm doing already, I don't know that I'm going to really do any, I don't know what I'm going to gain from it. So he said,
just take Nexium.
Yeah, but again, Nexium taking every day has side effects. So,
what
it's
side
better.
Effects does it have?
Read on it. It has side effects.
Nexium?
Yep. And it's called a protein pump inhibitor, PPI. Yep, they have side effects. So long-term use, again, taking it once in a while is not a problem, but long-term use has side effects.
Every day.
So you'd be better off to change your diet, and when you eat and how you. I mean, you could read on it. There's a whole different ways of doing it than just popping a pill. Popping a pill is usually not. Remember, we were not designed to function by taking medicines, right? I mean, there's certain medicines that would be vital to take. You need to control your blood pressure. If you can't control it with diet and exercise, you need to take medicines. If you have an infection, you need to take antibiotics, because if not, you can die from it, right? I mean, again, I told you, you could talk to your grandparents. They will know of relatives of people that they grew up with who died from a cut, that got infected before there were antibiotics. If they lived before the Second World War, because antibiotics are only since the Second World War, they would they would know people who got a cut and died of an infection. So, I mean, there's certain things you do have that are good, but just to take a medicine because you have indigestion, okay, that you might be able to control, I wouldn't do that. If you can't control it, then yes, I would, because having reflux leads to what's called erosions in your esophagus, which raises your risk for having esophageal cancer. So, yes, if you couldn't control it any other way, then, absolutely you need to take medication. But I would always try. Remember, the easiest thing for a doctor is to prescribe a medication, because they're judged, or they're graded on how happy you are and how they've taken care of your condition. So, they want to look for an immediate fix. And most of the times, the reason you have the problem is because of not eating right, not exercising, and most of our health problems. So most of your health problems could be fixed with, some diet and exercise. Okay. Somebody asked, what's the angina difference than general chest pain? So angina means that we know why they're having chest pain, right? In other words, they tell us they have angina, means that they had procedures done where they know that the inside of their arteries has that fat. Okay. General chest pain could be caused because I punched you in the chest, because you have a pneumonia, because I don't know. I mean, when you say somebody has general chest pain just means they have pain in their chest. They could be they have a pneumothorax. So angina means that they have a diagnosis of that the reason they're having chest pain is that their heart is not getting enough oxygenated blood. Okay. Don't you need the acids? So absolutely. So somebody, in other words, do you need acid to dissolve food? Yes. Okay. There are some people, okay, who produce too much acid. Okay. So in that case, that could be their problem. So again, that's why you need to find out why you're having the problem you're having. But in my situation, I know my diet is not what it should be, as far as I shouldn't say not what it should be. Well, it is not what it should be. I should be eating healthier, but I know that there's certain foods I could cut out that will help me dealing with my reflux. And I just need to be better about it. So I mean, like I used to make an omelet and use a whole, half of a whole onion, chop it up and put it in the thing. So now I don't do that. I use a little less, and stuff. So just have to be a little careful. I'm also careful not to eat, after a certain hour, so that when I go to bed, I'm going to bed, I don't want to say hungry, but I'm not going to bed with a full stomach, because that also leads to reflux. Just have to be careful. So, and stuff. But I mean, I just, what was it, Tuesday? Tuesday, I just did I didn't even realize there's good challenging hikes right on Kakiak up on 202, but there's I read that there's this challenging hike in Kakiak, and I have to say it was quite challenging, and I didn't wind up getting any, I did my typical, I didn't eat, and I went up to the top and I ate breakfast up at the top. So I didn't have any chest pain on the way up, and then on the way down I felt a little bit, but it's just the food trying to, work its way around in your stomach when you're exerting
When somebody has stitches, it's technically the same thing, right? When somebody walks very fast or a lot right after eating.
Stitches where? What do you mean? Like current stitches? Like fresh stitches?
When somebody walks a lot right after eating, they will have pain in the lower left of their
abdomen. So that's a different reason. So when you eat, when you eat food, okay, so let's say you like Shabbos, you have a big Suda, right? So you've eaten a lot of food. The way your intestine is able to move food through your intestine, right? In other words, how's that food moving through? So what happens is your intestine, all your tubes are what they call smooth muscle. So they are muscle. So the muscle is actually, the intestine is actually squeezing and moving the food through, okay? So when you have more food, more blood has to go to your stomach to digest food. So since more blood is going to your stomach, less blood is going to other parts. So that's why you would probably feel tireder and you get some pain in different places and stuff, because there's just a certain amount, you only have a certain amount of blood. So if you're sending twice as much blood as you usually do to your stomach, then some other place has to get less blood. So that's why sometimes you may feel, I don't usually get pain. Like if you get pain with digestion, it could be more like you're eating fatty foods and maybe you're getting a little pain in your pancreas or your gallbladder, just because, they help with the digestion of fatty foods. So if you're kind of, straining them because the food you're eating is fattier. But if you shouldn't probably get that kind of lactic acid pain just from eating food. If you're not doing, if you ate a big meal and you went for a walk, then I would say yes. Okay, but if you're just sitting around, you probably shouldn't.
Right, that's what I was referring to.
Okay, yeah, absolutely. Like if you're eating a big Suda, on Shabbos and then you want to go out and walk so you kind of, settle it down and be able to take a nap, then yes, you're probably more likely to get pain because more blood is going to your stomach. That's why when you eat a big meal, you feel tired, so that, and also because you tend to secrete more insulin when you have more sugar, right? So if you're eating a big meal and you have a lot of sugar, you secrete a lot of insulin and it starts to drop your blood sugar. So you also start feeling, tired from that reason. Okay, so anything else before we get some rest, or at least I get some rest?
I want to go ask you about pediatric.
Okay.
I read a book, not our book, but a different book. It gave for infant that's below 15 kilograms, an anaphylaxis.
So that's about 30 something pounds.
Yeah, so you don't give 1.5, you give 1.1.
We never give 1.5. Pediatric dose is 0.15.
Yeah, okay, but that's what I mean. I mean the 0.15, and but
They're
read
saying
that
give less.
Someone, yes, is
Yeah.
that true?
So, but that's only going to work if you're actually drawing up the medication. Okay, so the auto injectors only have 2 doses, 0.15 and 0.30. So if you had a very, very small child, okay, and again, so 30 pounds is about half. So we usually say a child is under 66 pounds. So if they're only 30 pounds, you're talking, a smaller child, probably 2-3 years of age, maybe even, 2 years of age. So if it was more of a, if it was more of a precise administration, then yes, they probably could get a little more. But again, we're only treating life-threatening anaphylaxis. And these kids typically have young, healthy hearts, right? They have no cardiac disease. So I wouldn't worry at all about giving them 0.15 milligrams. If they're, as long as they're under 66 pounds, I would give them the full 0.15.
Now, in albuterol, it says 2.5 milligrams in 3 milliliters. What does that mean? What do you mean in 3 milliliters?
Good. So you're giving actually 2.5 milligrams of the drug diluted in 3 mLs of normal saline. So in other words, they're adding the drug to salt water. Okay, that's all that means, but that's good. Okay.
All right.
And that's the same.
How is milligrams possible when it's
it's volume?
Yeah, when it's volume, liquid, whatever.
So again, the drug was probably in a powder form, okay, and it was added to the fluid. Okay, so in other words, the milligram is the measurement of the amount of the drug. The milliliter is the amount of fluid that it's in. Again, don't make yourselves crazy. It's not going to be a test question. But for those of you that know a little more, so one is a measurement of the amount of something, right? Milligrams. The other one is the amount of fluid. So like milliliters, liters, milliliters is more of a fluid measurement if you know the metric system. So, but it's not going to be anything they're going to ask you on the state exam. Just a knowledge point.
I got one small one, maybe a little stupid one, but
no, it's not stupid.
If someone is craving for sweet candy and stuff, does that mean he's low in sugar? Does that mean that something's wrong with his glucose? Something?
So that's a good question. It definitely means that he should probably discuss it with his doctor, and what they'll probably do is what's called a glucose tolerance test. It's something they sometimes do with women when they're pregnant and stuff, and they think they may be developing gestational diabetes from the pregnancy. Some people have what they call a sweet tooth, right? Some people, that's what their enjoyment is. Doesn't mean anything. There's a lot of other questions you'd have to ask, are they overweight? So there's a lot, but I mean, it's probably worthy of a discussion. Do they have any family history of diabetes, and all that kind of stuff. It's probably something worthy of, talking to a doctor who's actually interested. Sometimes you get, don't worry about it. You have a sweet tooth, but, it's probably worthy. Other things to ask them, do they urinate very frequently, right? So one of the warning signs of diabetes is that you urinate very frequently. Okay. Now, if you're when you get older, men tend to urinate a little more frequently because it's harder for them to completely empty their bladder. So they tend to urinate a little bit. Like at a younger age, if you start urinating frequently, that could be a pre-diabetic sign, because what's the body trying to do? Get rid of the sugar. So, but so it's probably worthy of at the very basics, a blood test to see what your resting blood sugar is. So what they'll do a fasting blood test where you stop eating at dinner and then you take the blood test the following morning. And so you haven't eaten for like, say, 10 to 12 hours. And they'll do a fasting blood test to see what that comes back at. And then the next one, they'll do what's called a glucose tolerance test, where they'll make you drink a very sugary solution, and then they'll see how long it takes you to process all that sugar out of your system.
Got it.
Yeah, I would say it's probably worthy of, at least a discussion. I mean, worst comes to worst, it's going to be a trip to the lab and get a blood test and see what happens. But again, I would, look at, are they overweight? Okay. Any history of excessive, frequent, I shouldn't say excessive urination, but more frequent urinations, any family history of diabetes, and so on. Are they thirsty a lot? And stuff like those are all kind of pre-diabetic warning signs.
Well, Frank, is there any way to know if it's a VTech or a VFib without having a monitor from a paramedic?
No, unless you have an AED that has a screen and you know EKG interpretation. No. Well, yes, there is. I'm sorry. Did you say if there's any way of knowing if it's VFib or T? If they're dead, then it's obviously VFib. If they're alive, then it's if they're alive in a fast rhythm, I think the question would be, do you know if it's VTAC or SVT? And then the answer would be no, you need EKG. So if they're dead, it's clearly VFib. Okay.
I mean, if they're dead,
no pulse.
In a VTAC, you're gonna have a pulse.
It depends on how fast it's going. You may be alive in VTAC, right? It just depends on how fast it's going and what your condition was. I mean, you won't be alive for days, right? I mean, you're not going to tolerate VTAC for more than a couple hours. But yes, you could be alive in VTAC. I just had a guy in the summertime, basically called because he had gastric bypass surgery. And he felt like he broke out in a cold sweat, and he felt like he was having pain in the, the area he usually has pain if he eats too much. So I totally thought he was just having something with his, gastric bypass surgery and stuff like that. And I went to feel for a pulse in him, and his skin was icy cold. It was the middle of the summer. And I'm like, well, your skin's icy cold. He said, yeah, that's why I called you, because I know that's not normal. And I said, you're really just having pain in your stomach, not pain in your chest? No, I'm having pain in my stomach. I said, your heart racing? No. And I tried to put him on EKG, but he was so sweaty, they kept on falling off the electrodes, that we put on the skin. So one of the cops helped me hold them in place, and he was in VTAC. So then he tells me he has a history of VTAC. Before that, he only told me his history was that he had gastric bypass surgery. Then he told me he had to be shocked a bunch of times. I was like, oh my God, he was a train wreck. He had a very extensive cardiac history, but he didn't tell me. So, but he made it down to the hospital fine. There's no issues or anything like that.
If you come to a cardiac arrest and you just feel no pulse, then it's definitely a VFib.
No, because it could be
if you give the VTAC.
No, so if you come to someone without a pulse, okay, and they have no signs that they've been dead for a long period of time, so you have to try to resuscitate them. You're asking me what rhythm they could be in. So they could be in VFib, they could be in asystole, they could be in what they call pulseless electrical activity, where they have an organized rhythm electrically on the screen, but no pulse with it. The only way you would know they're in VFib is if you put the AED on them and the AED says shock indicated and charges up. So that's the only way you would know they're in VFib without having an EKG.
You're not gonna find somebody with no pulse on a VTAC rhythm.
You could find somebody with no pulse in a VTAC rhythm. It is possible. Okay.
Now, VTAC is not going to put you into VFib eventually?
It could, yes. That's what I said. I said, you're not going to stay in VTAC for a long period of time. Absolutely. VTAC is a very unstable rhythm. I mean, I could actually show you what it looks like.
It's basically, in VFib, the heart just quivers, right?
In VFib, the heart, right, is just shaking.
Yeah, but in VTAC, it's basically pumping very fast, and you might not feel a pulse because it doesn't throw any blood around.
Right.
Right?
Yep. Here, so. Well, it's not actually a. Well, this is actually a good one to look at for a second, and I'll try to find the other one. So this is a patient in VFib, right? It's not the perfect picture of VFib, but whatever, just pretend it's VFib. The defibrillation typically shows up on the paper as a big spike. And this defibrillation worked to convert the VFib into a normal rhythm. So that's what you would want to see, in a patient.
You mean that line was a shock and then it kept normal?
Yeah, usually it looks like a big spike. Here, let me show
Got
you.
it.
I think that they kind of drew over the spike to, emphasize it.
You had one in that picture. In the black box, you had one.
When I just clicked on.
Yes, yes.
Okay, hold on. Where was it now? Here.
So right here, the second one, yeah, that one.
Yeah, that's a slightly different than a defibrillation, but that's what it would kind of look like. Let's see. Yeah. Usually it's a little more solid, but yes. But this is not VFib. This is AFib, atrial fibrillation. So this patient was alive, but the only way they were able to break it, I guess, is by cardioverting this guy. But they cardioverted him. It's a different form of defibrillation. It's a more.
Is this is what happens when someone gets an electric shock and he gets a different rhythm?
You mean accidentally?
So you shock him to get it back?
Accidentally getting electrocuted?
Yes.
No.
Yes.
No.
So what puts the heart into the rhythm over here that they should need a shock to put it back? Yes.
Atrial fibrillation is typically just an older heart, but it can happen in younger people, especially if they have problems with high blood pressure and stuff like that. It just means that, so the way the heart normally works, here, I'll show you.
When it says atrial fibrillation, does that mean the right or left side?
Both.
Or both?
Usually both, but it can only be one chamber and not the other. So this is an easy one here. And then I'm going to have to get some sleep. Okay, so right atrium, right ventricle, left atrium, left ventricle. Okay, so we have these special nerves that have the ability to initiate its own impulse. Okay, so the SA node is what they call the dominant pacemaker. It means it's set to run the fastest, beat the fastest. It's set to beat 60 to 80 times a minute because that's what our normal heart rate is, right? That's why our normal heart rate is 60 to 80 beats per minute. If that fails, then you have a backup one called your AV node that's set to beat 40 to 60 beats per minute. If that fails, the ventricles themselves can beat at 20 to 40 beats per minute. So what should happen is that the SA node should send out an electrical symbol that starts to travel through these wires, okay? Once it starts traveling through these wires and you see there's a branch to going over to the left atrium, it will cause both atriums to contract and push blood down to both ventricles, okay? So there's a slight pause in that electrical signal before it goes down into the ventricles to allow the atriums to squeeze and push blood down into the ventricles. Then once it gets down into the ventricles, and obviously it's showing you the valves in between, so for blood to be coming from the atriums into the ventricles, the valves have to be open. Now, once the ventricles are completely filled, the valves between the atrium and the ventricles close. The valves at the bottom of the ventricles that either go into the pulmonary artery or the aorta have to open because that's where blood is going to go out into. Then the impulse travels down. And again, this is like this. I mean, I'm talking, but it happens like this. The impulse travels down, okay, and the splits to wrap around both sides of the ventricle and causes the ventricle to depolarize. The right ventricle obviously pushes out into the pulmonary artery and goes to the lung. The left ventricle pumps out upwards, up into the aorta, okay, and then the aorta arches and comes behind the heart, right? So you have the arch and then it comes back down. So that's your cardiac conduction system. When somebody has AFib, what happens is instead of these being in command, some little part in either one or both of the atriums starts sending out signals faster than that 60 to 80 that this can. And the heart always listens to whoever sends out signals the fastest. So because some little part, that's the interesting thing about the entire heart has the ability to initiate its own impulse. It never does because it listens to these. Okay, but if sometimes you get like a little bad boy section of the heart and starts sending out impulses, and it's faster than what should be over here, it will start listening to it. In atrial fibrillation, there's not just one, but there's lots of them. Okay, and that's why when we were looking at that picture, I don't know if we still have it up there. When you're looking at it, you don't see any one, like here where it's a normal heart rhythm, you see one little bump and then one big bump. So that's the atrium, the SA node, and that's the ventricles. Here you see lots of little bumps because there's multiple sites in the atrium all sending out signals. Just like in VFib, it's very chaotic. Here it's the atrium being very chaotic, but the ventricles are working fine. Since the ventricles are working fine, the patient is alive. Okay, but they're just not getting the right amount of blood from the atrium down to the ventricles, so it's not a perfect rhythm. Okay, and the other problem is if the atriums don't completely empty, right? If these atriums don't completely squeeze out blood because they're kind of shaking and not pumping, you can get clots that develop, and then people can have strokes if the clots come up into the aorta and then get up into the blood vessels that go up to the brain. So that's the problem with atrial fibrillation.
Frank, when you started, you said that the SA node sends out a message.
Impulse.
Basically, it's to the.
It's actually electricity. It sends out an electrical shock.
But both of them work. The SA node sends it to the AV node, and then it sends the bundle of His down to the rest, right?
No. So what happens is if it's working perfectly, the only time the AV node will send out the signal itself is if the SA node doesn't. So it will travel through the AV node, but the AV node will actually not send out another signal. It'll just take the signal from the SA node and pass it along. Because again, this is set to run faster. So it doesn't need to fire as long as this is firing. So it will go through it because it's in the way, but it'll only start to send out its own signal if it doesn't get a signal from above because it's a
understood.
backup.
But doesn't the SA node first send the message to the atrium that they should push down blood before before the second press, which happens in a second, but the atrium push down the blood first, and then the ventricles push it back out. So it gets one message from the SA,
and the AV node holds that, and the AV node holds that message for a millisecond, a very short period of time, to let the atriums empty, and then it sends it back on.
Then it pushes it out. Okay,
right, but it's not sending a new signal. It's the same signal.
It's the same signal going through. It just takes it for a second. Okay.
Right. Remember, when we say a signal, it's really just like it's like a little bolt, a tiny little bolt of electricity. It's like sending a little electrical charge to make something happen. Okay. So let's just finish up because I'm tired and I need to be up early tomorrow. So let's. So somebody, do you need acids to digest food? The answer was yes. The upper part of your stomach digests food with acid. The lower part digests with bacteria. So you do need some acid, just not too much. Somebody else wrote, I find avoiding coffee in the morning very important if you have reflux. Caffeine, okay, definitely adds to reflux. So yes, I drink tea, not coffee, and I used to use 2 tea bags, and now I only use 1, so it's a little better. How many VFib there is in a body? I don't know what that means. How many VFib there is in a body?
Nothing means, just joking. You can.
Oh, okay. Okay, so anyway, I mean, I don't know about you guys, but I thought this was a great class from my standpoint. A lot of good questions, a lot of good answers. So I was pretty impressed. So we'll pick up again on Motzei Shabbos, okay? And, you know, hopefully we'll have as good a class, but I do want to start going over some questions. I know you all want to be brain surgeons, but you have to pass the state exam. So I got to first make sure you pass the state exams, then we'll make you brain surgeons, okay? So anyway, have a great rest of the week. Have a great Shabbos. Get some rest. And we'll pick up again on Motzei Shabbos. I think I've made it for 8:30. I sent out the Zoom invitation, okay?
Yep. Thank you very much.
No problem. Have a great night, everyone.
Shabbos.
Take care.
Take care.